The filtration. So any doubt on the previous page?
No, thank you.
No, thank you.
Okay, so let's discuss the filtration. Okay, so for that, first you need to know about the filtration fraction. Okay, how much of the substance which is entering into this kidney via the afferent arterioles, how much of the substance is filtered into the Bowman's space? Okay, so out of all the flow, all the substance, or you can say all the flow of blood or the plasma which is given to the kidney, okay, how much of it get filtered via GFR? This is the filtration fraction. So you can see that the total of RPF is given to the kidney, and out of it the GFR is filtered in the Bowman's space. So the filtration fraction will be equals to GFR divided by the renal plasma flow, and the normal filtration fraction is equals to 20%. And as you already know, that around 20% of the PAH is absorbed via GFR, and the remaining 80% is secreted via the epithelial cells. So that makes sense that a normal filtration fraction is 20%. Almost 20% of all the blood, okay, which is given to the kidney, it will be filtered via GFR, and and then if there is a substance who could be secreted by the cells, it would be secreted, right? So the GFR is always 20% of the total renal plasma flow. How you can calculate a filter load? Okay, it would be the plasma concentration of the substance multiplied by the GFR. Okay, so GFR, it will be in the milliliter per minute, and the plasma concentration will be in the milligram per milliliter. So you can uh, easily cross this milliliter by milliliter. So we'll get a filtration load will be milligram per minute, right? That makes sense. So filtration load will be equals to the plasma concentration of that drug multiplied by GFR. Okay, so that's how you can calculate the filtration load. Okay, let's discuss the different substances. Okay, so, certain hormones that act on the efferent arterioles and the afferent arterioles. Okay, so you know that the blood always enter into the afferent arterioles, then it reaches the Bowman's capsule. Okay, it will be filtered into Bowman's space, and then the remaining of the blood will enter into the efferent arteriole and then go to the veins, right? So you have first the NSAIDs. Okay, and the function of NSAIDs is to decrease the prostaglandins. Now whenever you have a low blood flow to the kidneys, kidney always releases the prostaglandins in order to dilate the afferent arteriole so that the blood flow to the kidney could be increased. In a scenario where you give the patient NSAIDs, the prostaglandins will be decreased, and as a result you will have a constriction of the afferent arterioles. As a result, the renal plasma flow will be decreased. Okay, and as a result we have a low GFR, because if there is if there's a low flow of the blood, then you will have a low GFR. Okay, so the prostaglandins, they preferentially dilates the afferent arterioles. Okay, their function is to increase the renal plasma flow, and so that the GFR. But please note, they do not increases the filtration fraction. Okay, because how much whatever blood you give to the kidney, only 20% of it will be filtered via the hyperfiltration of this GFR, right? So the filtration fraction will always remains 20% whenever you constrict or dilate this afferent arterioles. Because initially, if you have around 100 ml of blood passing through this afferent arteriole, around 20 milliliter of this blood will be filtered. Similarly, if you constrict the afferent arteriole and now you have only 50 milliliter of the blood passing through this with this part of the nephron, then you will have only 10 milliliter of the blood to be filtered, right? So the filtration fraction will remain same. Okay, only the GFR will change. Okay, now at the initially you are having a GFR of around 20 per minute, but when you vasoconstrict the afferent arteriole, you will have a GFR around 10 milliliter per minute, right? So the GFR is increasing or decreasing by changing the tone of this smooth muscles in the afferent arteriole, but the filtration fractions will always remain same whenever you vasodilate or vasoconstrict the afferent arterioles. Is that okay?
Yes.
Yeah.
Okay, so that was the NSAIDs, which decreases the prostaglandins, and that's why they will decrease the blood flow to the kidneys. So as you can see, whenever you have a low blood volume, okay, any kind of a hemorrhage or dehydration or anything, any burn or any shock, any kind of a shock in which you have a low renal plasma flow, in that case, you need the prostaglandins, okay, for my kidney to survive. If you give the patient NSAIDs in any case of a shock, then they can have a necrosis of the kidney. Is that okay?
Yes.
So do know this fact: whenever you have a shock, the NSAIDs are always contraindicated because it can damage your kidneys by hypoxia. Okay, then you have the efferent arterioles. Okay, and the main drugs that act on the efferent arterioles are the ACE inhibitors. Okay, you have the angiotensin 2, okay, that constricts or dilates the efferent arterioles. Whenever the angiotensin 2 is present, it will constrict the efferent arteriole. Okay, and whenever the efferent arteriole is constricted, what you can see, due to the constriction, you will have an increase in the hydrostatic pressure, right? In the capillaries, you will have an increase in the hydrostatic pressure because of the constriction, right?
Yeah. Yes.
Whenever you have a increase in the hydrostatic pressure inside the capillaries, can you have a more filtration?
Yeah.
Yes.
And as a result, whenever you have a constriction of the efferent arteriole, you will have a increased filtration fraction. Initially, when I was giving a blood of 100 ml, only 20 ml of the blood was filtering via GFR. Now, if I vasoconstrict my efferent arteriole, instead of 20, because of this increase in the hydrostatic pressure, I can have a 30 or 40 milliliter of this blood to be filtered. Right?
Yes.
So, as you can see, the afferent arteriole, the blood flow is constant 100 ml, but because of a constriction in the efferent arteriole, I will have a more filtration. So, whenever you vasoconstrict the efferent arteriole, you will have a high filtration fraction. Whenever you vasodilate the efferent arteriole, you will have a low filtration fraction. What about my GFR? It is, of course, increased. And because of this constriction in the efferent arteriole, you will have a decreased renal plasma flow. Okay, because the pressure in this region is increased, so the blood flow to this portion will be decreased, right? Is that okay?
Could you
Yes.
repeat that, please?
See, you need a pressure gradient to for the blood flow, right?
Yes.
Initially, let's say you have a 5 mm of Hg pressure at that side, only a 2 mm of Hg pressure at that side. So the blood can easily flow from here to here, right?
Yes.
When you constrict the efferent arterioles, the pressure in this region will rise.
Yeah.
Let's say it become 4 mm of Hg. So can the blood flow will decrease or it will remain same?
For efferent,
Initially,
it
I,
decrease.
initially I have a pressure of 5 mm of Hg here, 2 mm of Hg here. Now because of the vasoconstriction, I'm having a 5 mm of Hg here and 4 mm of Hg here. Initially, I had a pressure gradient of around 3 mm of Hg. Now I'm having only a pressure gradient of 1 mm of Hg. So does the blood flow will remain same or will it decrease?
Please.
Decrease, right? So whenever you constrict the efferent arteriole, you will have a decrease in the renal plasma flow. Because of this increase in the pressure, you will have a high hydrostatic pressure and that will cause a more GFR, okay, and you will have a more filtration fraction. Is that okay?
Yes. Got it. Thank you.
Now see, you also have a pressure in the Bowman's space that will oppose the filtration, right?
Yes.
So whenever you have a more uh, fluid in my tubules, I will have a more Bowman's pressure, this hydrostatic pressure in the Bowman's space, right?
Yeah.
So as you can see, whenever you have any stone obstruction in the ureters or whenever a vesicular reflex is present, it will increase the pressure in the Bowman's space,
Yes.
right? Because ultimately all of this tubule will connect it to your all the ureters, right? At
Yes.
the very end. So
Yeah.
whenever you have a blockage in the ureter, all this pressure will be backflow in the tubules. So it will increase the pressure in the Bowman's space, right?
Yeah.
So does my filtration fraction will remain same or will it decrease?
Decreased.
Exactly. And what about my blood flow to the kidney? The this RPF, will it remain same or decrease?
Remains normal.
Yeah, it will remain normal, right? Because the capillage has nothing to do with this hydrostatic pressure, right? The blood flow will remain constant, but it will oppose the filtration of this blood. So you will have a normal renal plasma flow, a decrease in the GFR, and a decrease in the filtration fraction. That's what you will get whenever you have any kind of obstruction in the pathway of urine, right?
Yes.
So do know about all these agents. The prostaglandins, they will act on the afferent arterioles, decreasing or increasing the renal plasma flow, but the filtration fraction will remain same. Angiotensin 2, it will inhibit, the ACE inhibitors, they will inhibit the angiotensin 2. Okay, so basically they will cause the dilation of the efferent arterioles, decreasing the hydrostatic pressure, and as a result, low renal plasma flow, high renal plasma flow, low GFR, and low filtration fraction whenever you give the patient ACE inhibitors. Is that okay?
Yes.
And because these ACE inhibitors are decreasing the hydrostatic pressure in the glomerulus, they are renoprotective. That is the main reason why they are renoprotective, okay? Because they're decreasing the hydrostatic pressure in this uh, in the glomeruli, okay? So they're preventing a damage of all this endothelium layer and the podocytes, okay?
Yes.
And in case of my diabetes mellitus, you're gonna have a non-enzymatic glycosylation of all these proteins, and they will start depositing in the efferent arterioles. And because they're depositing in the efferent arterioles, it will make the lumen very narrower, right?
Yeah.
So it is same as having a this vasoconstriction in the efferent arteriole. So it will increase the hydrostatic pressure there in the glomerulus. Okay, and because of this increase in the hydrostatic pressure, you're gonna have the pathological changes in the in this glomeruli. You will have a thickening of the basement membrane, you will have a filtration of the proteins, right? So that causes the kidney damage whenever you have a diabetes. And exactly that's why you need the ACE inhibitors. You will give these drugs, you will vasodilate the efferent arteriole, you will decrease the pressure on the glomerulus, and as a result, the kidneys will be protected. Is that okay?
Yes. Okay.
Yeah.
The more we'll discuss in the later part of this chapter, okay? Now let's see what changes you will see with different agents. So if you constrict the afferent arteriole, as we've already discussed, you will have a decrease in the renal plasma flow. And if the renal plasma flow is decreased, then you will have a low GFR. The filtration fraction will remain same, because filtration fraction is a ratio of your GFR divided by the renal plasma flow, right? If you constrict the efferent arterioles, the renal plasma flow will decrease because of increasing the hydrostatic pressure. The GFR will increase, and you will have a super increase in the filtration fraction. If you increases the plasma concentration of the proteins, okay, like the albumin, for example, then presence of a protein or a solute in the blood, it will oppose the filtration, right?
Yes.
Yeah.
So if you increase the protein concentration in the plasma, it will oppose my GFR, it will decrease the GFR, the renal plasma flow will remain same, and you will have a decrease in the filtration fraction. Similarly, if you decrease the plasma proteins, that can happen in the nephrotic syndrome, or a malnutrition case maybe. Okay, in that case, you will have an increase in the filtration of all these solutes. You will have an increase in the GFR. With a normal renal plasma flow, you will have an increase in the filtration fraction. When you constrict the ureter, like any kind of a stone or anything, okay, if you somehow ligate the ureters, in that case, they will increase the hydrostatic pressure in the Bowman's space. That will decrease my GFR, but my renal plasma flow will remain same, because it has nothing to do with the pressure in the Bowman's space. Whenever the hydrostatic pressure will rise, I can have a low renal plasma flow, but it has nothing to do with the hydrostatic pressure in the Bowman's space. So you will have a low GFR with a normal renal plasma flow. You will have a decrease in the filtration fraction. Whenever you have a dehydration, you will have a low volume of the blood, and as a result, you will have a very decrease in the renal plasma flow. But now the protective mechanisms of the kidney will get activated. You will have a sympathetic activation. The sympathetic system will activate the RAS, that will activate the angiotensin 2. It will vasoconstrict the efferent arterioles. You will have a super decrease in the renal plasma flow. but a slight decrease in the GFR. So ultimately, you will have an increase in the filtration fraction. Is that okay?
Yeah.
Although you're decreasing the AC initially, let's suppose in a normal patient, you're having 100 ml of blood flowing through my this afferent arteriole. Now he got dehydration, and due to this dehydration, he is having a decrease in the renal plasma flow to 50. Now only 50 ml of blood is flowing. Okay. Initially, I was having a filtration of 20 ml of the blood, but now the renoprotective mechanism will get activated and they will constrict the efferent artery. Also, they will increase the remaining hydrostatic pressure will be increased. So now, instead of getting a 10 ml of blood filtering through this glomeruli, now because of the constriction of this efferent arteriole, I can have a 15 ml of blood to be filtered, right?
Yes.
Right.
So overall, I'm having a loss of GFR. Instead of 20, I'm only having a 15 ml of filtration. I'm having a high decrease in the renal plasma flow. Okay, one because of dehydration, and second because of constriction in the efferent arteriole. Okay, but ultimately, I'm having an increase in the filtration fraction. Instead of 20% initially, I'm now having 30% of the GFR, right?
Yeah.
Okay, so I'm having an increase in the filtration fraction, super decrease in the renal plasma flow, and a slight decrease in the GFR whenever you have a dehydration. Now, because you're increasing your you're increasing your filtration fraction, so more of this fluid will be filtered from the capillaries, right? If I'm having a high filtration fraction, that means more fluid will be filtering through my kidneys to this glomeruli, right?
Yes.
Yeah.
Now, if you're filtering more fluid, what about the concentration of other solutes? Will it rise or will it fall? Like those solutes which cannot cross this filtration barrier, like the albumin, what about their concentration?
Increased.
It will increase, right? So if you have too much constriction of the efferent arterioles and that too much of the filtration fraction is present, it will eventually increases the concentration of all these solutes, including the albumin, which cannot cross this filtration barrier. So if the concentration of all these solutes increase, does they oppose my filtration?
Yeah.
And as a result, eventually you will have a fall in the filtration fraction. So acutely, you will have an increase in the filtration fraction, but after some time, if the dehydration pursues, the patient will get a fall in the filtration fraction because of increase in the concentration of non-filtrable substances, right?
Right.
So acutely, you will have an increase in the filtration fraction and a slight decrease in the GFR. Okay, but after some time, you will have a very high decrease in the GFR and a decrease in the filtration fraction because of increase in this oncotic pressure in the capillaries. Okay,
Yeah.
so that was everything on this page. Any doubt, please ask.
No, thank you.
No, thank you.
Okay, now let's calculate the reabsorption and the secretory rate. You guys already know about the filtered load. Okay, this is a concentration of this protein or this substance in the plasma multiplied by the GFR, right? And you also know the expiratory rate, that is the concentration of the substance in the urine multiplied by the flow rate of the urine, right?
Right.
Yes.
So tell me, if we have more excretion rate than the filtered load, that means I'm secreting my substance into the tubules via epithelial cells. Only that's why you can have a high excretion rate than the filtered load, right?
Yeah.
So that means if you have a more excretory rate than the filtered load, that means I'm secreting the substance. Okay. Similarly, if I have a low excretion rate than the filtered load, that means I'm reabsorbing that substance in the kidney, right? In the tubules.
Yes.
Yes.
Okay. So the reabsorption rate is given by the filtered minus excreted rate, and the secretion rate is given by the excreted minus filtered rate. a filtered load. Is that okay?
Yeah.
And that makes sense, because if you're secreting a substance, you will have a more excretion rate. If you're reabsorbing the substance, you will have a more filtered than the excretion, right? So the reabsorption filtered load is always more than the excretion load. In case of secretion, the excreted load is always more than the filtered load, right? Any doubt, please ask.
No, thank you.
Or no. Let's discuss this fractional excretion of the sodium. Okay, now the fractional excretion of the sodium is given by the this excretion load of my sodium divided by the filter load of my sodium. So among of this filtered load, how much of the sodium is excreted from my kidney, it is known as the fractional excretion of the sodium. So I have a filtered load from the GFR. Some of my sodium got filtered. Okay, much of the sodium got reabsorbed in the tubules, and the remaining one will be excreted from my kidneys, from my tubules. So how much of this sodium is excreted, okay, among this filtered load of the sodium, you call it a fractional excretion of the sodium. So the excretion rate of the sodium is given by the concentration of sodium in the urine multiplied by the flow rate of the urine divided by the filtered load of the sodium is given by the concentration of sodium in the plasma multiplied by the GFR. Is that okay up to here?
How did GFR be equal to sodium, which is filtered sodium?
GFR equals to filtered sodium.
Yeah, because when we consider sodium which is excreted, that equals to UV by P.
Yeah.
So that comes like U and V are in the numerator, P is in the denominator. So basically, it means that this denominator of the like sodium filtered means GFR. So how does that equal, like how does sodium filtered be equal to GFR?
Sorry, I'm not getting your question actually. You're saying the GFR equals to filter load of sodium.
Yeah, because according to the equation which is written, that's what I'm
Yeah.
able to comprehend from it.
The equation is just saying that the filtered load will be equals to the concentration of sodium in the plasma multiplied by the GFR.
Okay. Okay.
You can type your question in the chat box.
I,
We'll discuss
I'll
it
ask you
later.
on I'll ask you on WhatsApp then.
Okay. See,
Okay.
if you're not getting how this filter load is equals to this GFR into the into the concentration of this substance, I can explain that if you want.
Yeah, I get that, but my question is like we had studied an equation like the amount of substance which is getting cleared. Oh, sorry, I'm confusing it with clearance. I'm so sorry.
Clearance is a different thing, right? It
Yeah,
is
yeah, I
not the
got it.
GFR. Yeah.
Right, right. Yeah, thank you.
Okay, now see, the GFR, we already know that it is the clearance of my creatinine, right? Approximately equal to the clearance of my creatinine, right? The GFR.
Yeah,
So if I rearrange the equation, I can get what is the clearance of my creatinine. It will be the concentration of this creatinine in the urine multiplied by the flow rate of the urine divided by the plasma concentration of the creatinine, right?
right.
So the flow rate of the urine divided by the flow rate of the urine, they will got cancelled. Okay. The one in the denominator, it will go up. Okay. So I will get, after rearranging all these equations, I will get the plasma concentration of the creatinine multiplied by the concentration of sodium in the urine divided by the concentration of creatinine in the urine multiplied by the concentration of sodium in the plasma. Is that okay?
Yeah,
Okay, so this is the ultimate equation I will get for the fractional excretion of the sodium. And this is a very important concept that you must remember for this pre-renal, renal, and post-renal azotemia, right? Because in different scenarios, you will have a different fractional excretion of the sodium. For example, whenever you get a pre-renal azotemia, you will have a decrease in the renal plasma flow, right? In that case, you will have a more absorption of all this sodium, so the fractional excretion will decrease. Whenever you have an intrinsic renal failure, okay, In that case, you cannot reabsorb the sodium, and all of the sodium will be losing in the urine. So you will get a very high fractional excretion of the sodium, right?
Right.
Yes.
So for that thing, you need to remember this equation, that it will be equals to the excretory rate of the sodium divided by the filtration rate of the sodium. Any doubt? Please ask.
No, thank you.
No, thank you.
Okay, now you have the glucose clearance. Okay, and you know that the glucose has a transporter for its reabsorption in the tubules, right?
Yeah.
Yes.
Does anyone remember the transporter names?
SGLT2
SGLT2. And where does this SGLT1 found?
in the intestine.
In the intestine, right? The function of these transporters is to reabsorb both the glucose as well as sodium at the same time, right? So every transporter has a maximum saturation limit, right? After which it cannot transport that substance,
Yeah.
right?
Yeah.
Now, initially, I have a low sodium which is filtering in the GFR, entering into the tubules, and it is getting reabsorbed by my tubules. All these SGLT2 transporters, right? So look at the graph. In a normal circumstances, okay, if these transporters are not present, let's imagine if the transporters are not present, then whatever the amount of my this glucose is filtering via GFR, all of it will be excreting in the urine,
Yes.
right? So you will get this kind of a straight line, right? If I'm increasing the plasma concentration of the glucose, I will get a more filtration of the glucose, right?
Yeah.
Yeah.
Now, because of this presence of the transporters, I will get the absorption of all of this all of this glucose from the urine. Okay, so I do not get any glucose in the urine normally, right? So if I
Yeah.
increase the plasma concentration of the glucose, you can see the excretion of the glucose is almost zero because of uh, all this transport of this glucose back into the plasma, right? As you can see, if I'm increasing the filtration load, if I'm increasing plasma concentration, I'm getting an increase in the reabsorption, right?
Yeah.
Now, you already know that different transporters of the sodium has a difference in the saturation limit.
Yes.
Like one can reabsorb up to 100, some can 200, some can do up to 400, right? So every transporter has its own limit, right?
Yeah.
Yeah.
Now, let us suppose the transporter who has a minimum limit, okay, for the reabsorption, let us suppose it is in a normal life, it is 200. So whenever the plasma concentration of the glucose reaches 200, okay, some of the transporters got saturated with the glucose that they cannot reabsorb the glucose back into the plasma, and as a result, some amount of glucose is started in the urine, started coming in the urine, right?
Yes.
And a point reach where all of the transporters got saturated with the glucose, and that happens at a concentration around 400. At this concentration, all of the transporters in the kidney, the SGLT2s, they will get saturated with the glucose. Now they cannot reabsorb any much of the glucose, and all of the glucose, if I further increase, it will get excreted in the urine, right?
Yes.
Now, because of a presence of different transporting saturation limits of different transporters, you will have this kind of a curve, and this is not just play. This is not just play phenomena. Okay, it is because of the heterogeneity of the heterogeneity of the nephrons for the reabsorption of the glucose. Okay,
Yeah.
so looking at the graphs, you will have an increase whenever you have a more concentration of the glucose, you will have a more filtration of the glucose. But at the same time, all of the glucose is getting reabsorbed back into the plasma, and you will have no concentration or no presence of the glucose in the urine at all. A point reach where some of the transporters got saturated with the glucose, and now the glucose is started coming in the urine as this reabsorption is keep on decreasing. If you further increase the plasma glucose concentration, as you can see, uh, this glucose concentration in the urine is rising. a point reached where all of the transporters got saturated, and now all of this glucose, if I further increase in the plasma, it will excrete it in my urine. I got this kind of a graph. And the transport maximum is 375 milligram per minute. This is saturation limit of tubules, average saturation limit. Okay.
Yes.
So yeah, that's the thing in the diabetes mellitus. That's why you will get the glucosuria in the diabetes mellitus. Now, any doubt, please ask.
No, thank you.
No, thank you.
Okay. Now let's discuss the different physiology of different nephrons, the different transporters present in different nephrons. The first important question you can get from this page, that you know that all of my cells in the kidney, they uses the ATP, right?
Yes.
And they also use the oxygen. So step one will ask you where the majority portion of this oxygen and ATP is used. In what function majority of the portion of my O2 and the ATP is used. So please note it is used in the reabsorption of the solutes, because every pump in every part of my tubule, it requires the ATP for function, right? As you can see, every part of the tubule requires the ATP as a baseline pump to reabsorb the solutes, right?
Yes.
So the majority portion of this ATP is goes into running these pumps into the reabsorption. Okay. So whenever you have a loss of ATP in the circumstances, you will have a loss of these sodium potassium ATPase pump, and you will have a loss of reabsorption of the solutes. Okay.
Yes.
Yeah.
Okay. Now let's discuss the proximal convoluted tubules. Okay. Majority of the reabsorption happens in the PCT. Okay. They reabsorb almost all of the glucose, amino acids, most of the bicarbonate got. Just give me a second again. Okay, so majority of the substances got reabsorbed in the PCT. Okay, almost all of the glucose, amino acid, most of the bicarbonate, sodium, chlorine, phosphate, potassium, water, uric acid. Okay, they all get reabsorbed majority in the PCT. Okay, now let's discuss how they get reabsorbed. First, you have a baseline pump, which is the sodium potassium ATPase pump. It will pump out three sodiums out of the cell and pump in two potassium inside the cell. And as a result, the concentration of the potassium inside the cell is increased, and the concentration of sodium inside the cell is decreased. If the concentration of sodium inside the cell is decreased, okay, a concentration is gradient is created in the lumen, and this is the interstitium or the blood part. You will have blood on this side, and you will have the tubular lumen on this side. Okay, now a concentration gradient is created, okay, in between the lumen and the cell, and as a result it will drive the absorption of the sodium inside the cells via SGLT2 transporters. Okay,
Yes.
and because of this sodium, the glucose also get co-transported, and that's why the name SGLT2. Okay. Similarly, because of this loss of sodium inside the cell, it will drive the reabsorption of the sodium from the lumen in exchange of the hydrogen via sodium hydrogen pumps. And these are the same pumps where the angiotensin 2 acts. In the later part of the chapter, we discussed the function of angiotensin 2, and one of the function is to act on the PCT. In the PCT, this angiotensin 2 activates the sodium hydrogen pumps that will drive in the sodium and efflux out the hydrogen out of the cell, right?
Yes.
Now, this hydrogen will combine in the bicarbonate with the bicarbonate in the lumen, okay, and it will form the hydrogen bicarbonate, okay, or you can say the carbonic acid, it will form, okay. In the presence of this carbonic anhydrase, okay, this carbonic acid will be converted into the CO2 and H2O. See, this carbonic acid cannot cross this membrane, the plasma membrane. They cannot cross it. But the water can easily cross this plasma membrane. Okay, it will enter into the plasma membrane. In the plasma membrane, they have the CO2. Again, the water will combine with the CO to form the carbonic acid. Just same process. Okay, and then it will be it dissociate into the H plus and the bicarbonate. Bicarbonate got reabsorbed back into the blood via bicarbonate channels, and again this same cycle repeated. Okay, acetylamides are the inhibitors of the carbonic anhydrase. They will prevent the formation of water and CO2 from this carbonic and this carbonic acid, and as a result, all of this acid will be lost in the urine. You will have a loss of bicarbonate because of that, and that will make the urine basic. Is that okay? It will increase the pH of the urine, right?
Yeah.
Yeah, so
Now you
everything
have, yeah,
CT is driven by the sodium potassium pump. That is the very first step.
yeah. The ultimate thing is, remember, the baseline pumps are the sodium potassium ATPase pumps. They are driving everything.
Okay, thank you.
Okay, now more pumps you have are the chloride pumps. Okay, and please note the bicarbonate always get exchanged with the chlorine in order to maintain a negative charge inside the cell. Whenever you have a high bicarbonate load, you will have more excretion of the chlorine. Whenever you have a low bicarbonate load, you will have a more absorption of the chlorine to maintain the electrical neutrality. Okay, not getting my point?
Could you repeat that?
See, whenever you have a more bicarbonate,
Uh-huh.
okay, the body will try to get rid of the negative charge by excreting the chlorine.
Yeah.
Okay, whenever you have a low bicarbonate load, the body will need the negative charge, and it does that by increasing the reabsorption of the chlorine.
Okay. Yes.
Okay, you have the pumps, and just like the RBCs, if you guys remember, you have an exchange of chlorine with the bicarbonate. Remember the chloride shift?
Yeah.
Okay, so chlorine always get exchanged with the bicarbonate because they cannot live together, right? They always need to exchange. So this chlorine got exchanged with the base, which has a negative charge, like the bicarbonate.
Yes.
Okay,
Yeah.
so that's about my PCT. Please remember the angiotensin 2, acetazolamide, carbonic anhydrase, they all act on it here, right? Other important function of this PCT is, the PCT has this EPO releasing thing. Okay, the peritubular fibroblast around the PCT, okay, that releases the erythropoietin. Okay, you have the reabsorption of the phosphate in the PCT, and remember the PTH hormone.
Yeah.
Yes,
The
it causes.
yeah, this PTH hormone act on the PCT. It is not shown in this diagram. Okay, but you have the phosphate pumps here also. Okay, and this PTH inhibit these phosphate pumps, so inhibit the reabsorption of the phosphate in the PCT again. Okay,
Yeah.
and the 1-alpha hydroxylase, which activates on vitamin D3.
Yeah.
This 1-alpha hydroxylase also present in the PCT. Okay.
Yeah.
Now, does anyone know what is the concentration of all this fluid which is present in the lumen of this PCT? I mean, does it isotonic, hypertonic, or hypotonic, this fluid?
Hypo.
Hypo. Anyone?
ISO.
Iso. Any more? Any hyper one? No. Okay, so this fluid is always isotonic whenever it enters the PCT, because it is filtered via GFR, right?
Yes.
Yes.
So it is always isotonic whenever it enters the PCT. When it leaves the PCT, the concentration might get changed. But when at the time when it enters the PCT, the concentration will be same as that of your plasma. Okay, so it is always isotonic when it enters the PCT. Okay.
Yes.
Now around 65 to 80% of the sodium and water get reabsorbed in the PCT. Remaining will reabsorb in the later part of the tubules. And please note that the membrane of this PCT is permeable to water. That means the water can directly crosses the membrane of this PCT. As you can see, I've made this here. The water can directly cross this membrane without any transporters. Okay. While you will study in the later portion of these tubules, you need some transporters to absorb the water, like the aquaporins, because the because these tubules, it has no permeability for the water. But please note the PCT, it has a very high permeability for the water. Water can easily cross these membranes without any transporter. Okay,
Yes.
good. And around 65% of the potassium, doesn't matter whatever the concentration of potassium in your body is, whether it is a case of hypokalemia or the hyperkalemia, 65% of all the potassium which is filtered in the GFR, it will be reabsorbed into the PCT, okay, via potassium pumps. Okay. If you have a very high concentration of the potassium, if you have a very low concentration of potassium, or you have a normal concentration, doesn't matter. 65% of whatever filtered in the GFR, it will be reabsorbed in the PCT. It has nothing to do with the plasma concentration. Okay,
Yeah.
Yes.
do know this fact also. And it is always a isotonic absorption. That is the important thing. The fluid is always isotonic. Okay, it is around 30 milliosmium, 300 milliosmium per mole. Okay, not 30, it is 300 milliosmium per mole. Okay, and maximum water absorption occur here again. Around, as you can see, 80% of the water is getting reabsorbed in the PCT. Doesn't matter whatever the concentration of water in my blood is present. Okay, doesn't matter if I'm having the hypovolemia or a hypervolemia, if I'm having edema or anything else, doesn't matter. Okay, I will always have a 80% of water absorption in the PCT. Okay, so if the step one asks you that where does this water get reabsorbed maximum in case of dehydration, please note the answer is not this ADH. The ADH causes the reabsorption in case of dehydration, but that reabsorption occurs only of this 20% of the water. If you have a dehydration, the 20 the this remaining the 20% of the water got reabsorbed in the collecting duct via ADH mechanism. If you are having a state of hypervolemia, the 20% of it will be lost, but the 80% always got reabsorbed in the PCT. Okay, the concentration of all this water will changed by this 20% water only, right? The 80% always get reabsorbed. Is that okay?
Yes.
Yeah.
Oh, sorry, can you repeat that about the dehydration?
See, whenever you have a dehydration, you know that ADH will get activated, right?
Yeah.
Antidiuretic hormone, and whenever you get activated, it will cause the reabsorption of the water.
Yes.
And when it got the reabsorption of the water, okay, it doesn't in the collecting duct, right?
Yes.
So you will have a more water absorption in the collecting duct. But see, around 80% of the water is already getting reabsorbed in that PCT, right?
Yes.
So this 20% only will reabsorb in the collecting duct. So the whatever the game is, the ADS, the RAS, and everything, it's only acting on that 20% of the water.
Okay.
The remaining 80% is always getting reabsorbed in the PCT. It doesn't matter if you're in an edema state or if you're in a dehydration state. Only 80%, maximum of 80% get reabsorbed in the PCT. Okay, whatever the concentration of your blood is, it will get managed via the collecting ducts by the action of ADH, right?
Okay. Okay.
And see, whenever you have more acid in the PCT, okay, you don't want your PCT to be get damaged, right? Because if there is an acid, it can damage your PCTs, right?
Yes.
You don't want that. In order to neutralize the acid, you need some base, right?
Yes.
It could be either a bicarbonate, one thing, It could be ammonia, NH3, or it could be one more thing I'm forgetting. There are three things. I think it was a phosphate. Yeah, it was the phosphate. See, this phosphate, ammonia, okay, and the bicarbonate, they always combine with the hydrogen ions to neutralize them whenever I have a more hydrogens. Okay.
Yes.
By combining the hydrogen with the NH3, I will get a NH4 plus. By combining this hydrogen with the bicarbonate, I will get a carbonic acid. By combining this hydrogen with the phosphate, I will get a phosphoric acid, right?
Yes.
Right.
So the kidney will uses the phosphate, ammonia, and the this bicarbonate to prevent the damage from the H plus. That is again a very important thing to know. See, if you give the patient acetazolamide, can I'm having already a high concentration of bicarbonate in my tubules? I'm giving the patient acetazolamide, which are the carbonic anhydrase inhibitors. Am I already having a high concentration of bicarbonate in my lumen of the nephrons?
Yes.
Yeah.
Right? Now, if I already have a high concentration of bicarbonate, does my kidney needs this ammonia to neutralize my H plus?
No.
No.
No, right? So does my kidney secrete this ammonia in the lumen of the nephrons?
No.
No, and that's why one of the side effect of the acetazolamide therapy is the hyperammonia, right? Because you already have so much bicarbonate to neutralize the hydrogen ions, you do not need the ammonia to test that, right?
Mm.
So this ammonia will be present in the plasma only. It won't enter into the lumen. So you will get a hyperammonia as a side effect of the acetazolamide therapy.
Okay.
Okay. And please note this ammonia is always come from the glutamine. Remember all this cycle, the alpha ketoglutarate, glutamine, and the glutamate.
Yeah.
Yeah. Yeah.
And the major transport form of the ammonia is the glutamine in the blood, right? So all this ammonia will come from the glutamine. Glutamine will be present here. The cells will extract the ammonia from the glutamine and convert it into the glutamate. It will again get this the what do you call it, recycled, right? It will get recycled again. Okay. So please note the glutamine, ammonia, acetazolamide, bicarbonate, phosphate, all of these things are managed to cause the neutralization of the hydrogen ions. Okay. Now, any doubt on the PCT?
No, thank you.
So let's take a short break and then discuss the loop of Henle and the other part of tubules. Okay.
Sure. Thank you.
Okay.
Loop of Henle. Okay, so we are done with the PCT, and I told you majority of the reabsorption of solutes always occurs in the PCT. Whenever a step one question asks you, okay, they will give you a scenario of this hyperkalemia or the hyperkalemia, or maybe the dehydration case, and they will ask you where is the maximum reabsorption of the water occur in case of dehydration. So don't get confused and don't choose the collecting tubule. Only a 20% water get reabsorbed in the remaining portion of the nephrons. Almost 80% of the water got reabsorbed in the PCT. So always maximum. Doesn't matter whatever the concentration of water is, whatever the concentration of all these solutes is, right? All these substances will maximally reabsorbed in the PCT only. Then you have the thin descending loop of Henle. Okay, and let me draw this nephron. This is your Bowman's capsule. Okay, this is your PCT. Okay, then you have a descending loop of Henle. It has a thick portion and a thin portion. Okay, then again you have the ascending loop of Henle, a thin portion and a thick portion. Then okay, then you have a DCT. Okay, right, and finally you have a collecting duct. Okay, so we have discussed this portion, PCT, and now we have the this the descending loop of Henle. Okay, let's discuss it. It has no major transporters in the thin the descending loop of Henle. Okay, just note that it is highly permeable to the water. Okay, so it passively reabsorbs the water according to the concentration gradient. If you have more water concentration in the body, you will have a less absorption. If you have a if you're in a dehydrated state, you will have a more absorption of the water. So I told you when the urine enters here, okay, it will be isotonic. Okay, again when it leaves the PCT, it will be isotonic. When it enters into the thin descending loop of Henle, it was isotonic still. But when it passes through the descending loop of Henle, the water will get passively reabsorbed. And please note, it has no transporters, no channels, nothing, nada, right? Only the water get reabsorbed in the thin descending loop of Henle. So because of the reabsorption of the water, the concentration of all other solutes, it will increase. And so you will get a very high concentration of the solute. So please tell me now, in case of my PCD, all this filtration load, all this filtrate was isotonic. Okay, what about the filtrate in the descending loop of Henle? Will it be isotonic, hypertonic, or hypertonic?
Hyper.
Hypertonic.
Hypertonic. Yeah, it will be hypertonic as it passes through the descending loop of Henle. All the concentration of every solute will rise because of the passively reabsorption of the water. This part is impermeable to the sodium or any other solute. Okay, so it is known as the concentrating segment. Now tell me, if this is my PCT and then the descending loop of Henle and then this ascending loop of Henle, okay, if my water is reabsorbing in this descending loop of Henle as it passes through air, okay, where does the maximum concentration of this filtrate lie?
Lowest portion.
In the lowest portion of the loop of Henle. This is the portion where the maximum concentration of the filtrate load will lie. Okay, you will have, or you will always found the maximum concentration at the lowest point of loop of Henle. Even if you're in a very water-rich state, if you're in a demetrious state, for say, this portion of the nephron will be highly concentrated as compared to other portion. If you are in a dehydrated state, in that case, the ADH will be activated on the collecting ducts. It will be reabsorbing the free water, right?
Yes.
So again, as my urine or this filtrate passes through the collecting duct, in a dehydrated state I'm talking about, right? When you have a very low water concentration in the body. In that case, when the filtrate passes through this portion, okay, it will again become concentrated because of a free water reabsorption.
Yes.
In that scenario, the concentration gradient at the lowest part of my collecting duct is approximately equal to this portion. Okay, they will have a approximately equal concentration of the filtrate. Okay, in a dehydrated state, in a water-rich state, this portion of the loop of family is the maximally concentrated. In a dehydrated state, okay, the loop of Henle and the lowest portion of the collecting duct will be maximally concentrated. Okay.
Okay.
So do note this fact also. Now, okay, so any doubt on that this loop of Henle, descending loop of Henle? Any doubt?
No, thank you.
Okay, now you have the ascending loop of Henle, and it is opposite to that of descending limb. In the ascending limb, after this loop of Henle, the portion of descending loop of Henle, after this portion, every portion of my nephron is impermeable to the water. The cell membranes are made up of such like that they cannot transfer the water through them without the presence of any transporter. So from here, every part of the loop of every part of this nephron which has the transporter for the water can be reabsorbed through that portion. Okay, but not through the membrane. As you can see in case of loop of Henle, descending loop of Henle and the PCT, water is freely reabsorbing, right, without the need of any transporter. From there, the water requires the transporter in order to get reabsorbed. In DCT, in the ascending loop of Henle, okay, you have no transporters for the water, and as a result, this portion is totally impermeable for the water. This portion is impermeable for the water, but it has other transporters. Again, the baseline will be your sodium potassium ATPase pump that will draw out 3 sodium ions from the cell and draw in 2 potassium ions in the cell, right? So this creates a concentration gradient of the sodium inside the cell, so it will absorb the sodium. Now you have again the co-transporters, and now this co-transporters co-transport sodium, potassium, and 2 chlorine ions through them, right? So a sodium, potassium, and 2 chlorines ion, to maintain the electrical neutrality, they will get reabsorbed in the this ascending loop of Henle via this transporter. Loop diuretics inhibit this transporter, and as a result, all of the sodium, potassium, and 2 chlorine ions will be lost in the urine. Is that okay?
Yes.
Now, the concentration of potassium inside the cell is already very much high. You have the potassium channels on the lumen surface of these cells. Okay. Now, if the concentration of if the concentration of potassium is already very high, what happens whenever this channel got activated? It will cause the efflux of the potassium, right?
Yes.
Yeah.
Yes.
Yes.
Could you repeat?
Good. See, you have a very high concentration of the potassium inside the cell, both due to the presence of this transporter, the ATPase pump, and the presence of this transporter. See,
Yeah.
both of them are drawing the potassium inside the cell, right?
Yes.
So you have a very high concentration of potassium. Whenever
Yes.
the potassium channels open in the basolateral surface of the cell, that means towards the blood surface, the potassium will be effluxed from the cell and enters into the blood.
Right. Yes.
Similarly, you have a chlorine which is getting reabsorbed inside the cell. Whenever you have a chlorine channels activation, you will have a reabsorption of the chlorine, efflux of the chlorine from the cell inside the blood, right?
Yeah.
And when the potassium channels on the lumen surface got activated, they will draw out the potassium from the cell and enter into the lumen.
Yes.
Now, when the
Yes.
potassium in this segment enters into the lumen, it will increase the potential of the cell. It will make the potential more positive, right?
Yeah.
And that causes the opening of other parts, okay, like the channels for the magnesium and the calcium. Okay, because of the presence of a positive potential, the reabsorption of the magnesium and calcium occurs in between the cells. It will create a space between these two epithelial cells that will cause the reabsorption of the magnesium and the calcium. Is that okay?
Yes. Thank you. Yes.
So that is an important thing. Whenever you have whenever you have a efflux of the potassium, the potential will increase and that will reabsorb the magnesium and calcium. So if you give the patient loop diuretics, what's going to happen to this magnesium and calcium?
Decrease.
Decrease or increase? Reabsorption I'm talking about.
Increase.
You will have an increase in the reabsorption of the magnesium calcium.
No, you would pee it out.
Decrease.
Yeah, exactly. You will pee it out, right? You will have a decrease in the absorption of magnesium and calcium because no potassium efflux is present if you inhibit these transporters, right?
Yes.
So if the efflux of this potassium is not present, you won't have a positive potential here. If you do not have a positive potential here, you won't get the reabsorption of magnesium and calcium. And that's why you will have a hypocalcemia and the hypomagnesemia whenever you give the patient loop diuretics.
Yes.
Okay. And as the as the filtrate passes through my ascending loop of Henle, because it is impermeable to my water and permeable to all other solutes, all these solutes will get reabsorbed and the concentration of these solutes will decrease in this filtrate, right? So what's going to happen to my this filtrate as it passes through the ascending loop of Henle? Isotonic, hypertonic, or hypotonic?
Hypotonic?
Hypotonic, right? Because I'm absorbing all the solutes. So free water will be present more as this filtrate passes through the ascending limb, right? So let me draw this again. This is my PCT. This is my descending loop of Henle. then the ascending loop of Henle, then the DCT, and then the collecting duct. So when my when my filtrate passes through the PCT, it will be isotonic. It was isotonic, right? When it passes through the descending loop of Henle, it become hypertonic, right? At the
Yes.
lowest portion of this loop of Henle, it become maximally concentrated. As it ascend upward, you will have absorption of solutes. So more free water will be present in this filtrate. So as this filtrate ascend upward, it will become getting diluted, right? It will start getting diluted, right?
Yes.
And when it reaches the DCT, can it become maximally diluted?
Yes.
Yeah. So the maximum dilution of this filtrate is found in the DCT, because as it ascend upward, all of the solutes getting reabsorbed. Free water quantity will be increased. You will have a low concentration as this filtrate ascends upward. So at this point, the filtrate become maximally diluted, right?
Yes.
So regardless of the status, the volume status, if you're having a dehydration or you're having a hypervolemia, it doesn't matter. The maximally diluted segment is always the DCT.
Yes.
Okay, do note this fact also. Step 1 can ask you this. Okay, so you have the reabsorption of sodium, potassium, and chlorines. You will also have an absorption of magnesium and calcium through a positive lumen potential generated by the potassium backleak. This portion is impermeable to the water, so it makes the urine less concentrated as it ascends, so make the urine hypotonic. 10 to 20% of the sodium got reabsorbed through this part, and around 5 to 10% of the potassium got reabsorbed through the ascending loop of Henle. And as the urine ascends at the very high point, that is in the DCT, the urine become maximally diluted. Any doubt, please ask.
No, thank you.
Okay. Now comes the early DCT. Okay, again, this portion is impermeable to the water. It has no water transporters, as you can see. So water does not reabsorb here, but it does reabsorb the sodium and the chlorine. Again, on the basolateral surface, you have the sodium potassium ATPase that will create this potential gradient for the reabsorption of the sodium. Chlorine along with the sodium got reabsorbed via sodium chlorine co-transporters. Thiazide diuretics inhibit these transporters again. Okay, calcium also got reabsorbed through this portion, right? Because of this presence of the calcium channels. Okay, again, you have a sodium calcium antipodes, okay, that will cause the influx of the sodium and outflux of the calcium from the cell, and that's how the calcium got reabsorbed in the DCT. Okay, the PTH, the vitamin D, they all act on the DCT to reabsorb the calcium. Okay, so PTH has two functions. One on the the PCT to activate the vitamin D3 and to cause the loss of phosphate. In the DCT, it causes the reabsorption of the calcium. Is that okay? The
Yes.
PTH hormone.
Yes.
Okay. Now, you also have the chlorine channels. Okay, that will cause the reabsorption of the chlorine here. Okay, doesn't matter whatever the concentration of water in your body is, you will always have a maximally diluted urine in this portion. Okay, PTH acts here, it will cause a reabsorption of the calcium also. If you give the patient thiazide diuretics, you will have a more absorption of the calcium. Okay, so these channels, somehow the thiazide, these diuretics activating the this calcium channels, so you will have a more calcium absorption whenever you give the patient thiazides. Okay,
Yes.
do note this fact also. So regardless of the concentration of water, regardless of the water status, you will always have a least concentration of water in the DCT, because this portion is impermeable to the water, right? The modified cells of the DCT, these are known as what cells? Modified cells of the DCT takes part in the Renal.
Mesentery.
Yeah. What cell?
Mesangial cells?
No, the mesangial cells are the interstitial cells. These are supporting cells. These are the macula cells, right?
The macular
Yeah.
cell.
Yeah, the modified cells of the DCT are known as the macula cells. What is the function of my macula cells?
Hence the sodium.
Yeah, it sends the sodium delivery to the DCT. Whenever you have a low sodium delivery, it will activate the RAS. Whenever you have a high sodium delivery, it will inhibit the RAS. Is that okay?
Yes.
Okay, so that was about the DCT. Please ask if anyone has any doubt on the DCT. No?
No.
Thank
Now, I want to ask you one more question. Okay, I told you that this portion of the DCT is maximally diluted. Okay, but it also depends upon your water status. Okay, let's suppose you're in a very dehydrated stage. Okay, in that case, this portion is the maximally diluted portion. Okay, because it is impermeable to the water. In your collecting tubule, you're having an activation of the ADH that will reabsorb all the water, and that makes this portion maximally diluted, hypotonic. Okay,
Okay.
because in the lowest part of loop of Henle and the lowest part of the collecting duct, you're having a very high concentration of the urine, right?
Yes.
So
Yes.
that makes the DCT maximally diluted or the hypotonic. In a scenario where you are having a hypervolumic state, can I have an activation of ADH if I have too much volume of water?
Is that what same is?
What?
No.
If I have too much of the volume of water in my body, can I have an activation of ADH? Can I have a presence of ADH then?
No.
No. In that case, can I have a reabsorption of free water in the collecting tubules?
Okay.
No, right? Because you wouldn't put the extra chlorines in if you already have enough.
No.
No, I don't have, right?
No.
In that case, I will have a loss of water as my urine flow from DCT to the collecting duct, right? I will have a very isotonic concentration of my urine in the DCT, but my all this urine will become further dilute as it passes through the collecting duct because I have no transporters to reabsorb the water, right? Because ADH is not there to reabsorb it.
Yes.
In that case, in a hypervolumic state, the maximally diluted portion is the collecting duct, not the DCT.
Okay. Yes.
In a dehydrated state or a hypovolemic state, the maximally diluted portion is the DCT. So it depends upon your volume status. If you're having a too much of the volume, the collecting duct is the maximally diluted portion. If you're having a very low volume of water, in that case, the DCT become the maximally diluted segment. Regardless of the water status, the loop of Henle is always the most concentrated gradient, right? In case of a dehydration state, the collecting duct and the loop of Henle, they become the most concentration gradient. Sorry, the portions, most concentrated portions. Okay. Are we good? Should I repeat it again?
Repeat again, please.
See, if I am having a dehydration, right? Doesn't matter if I'm having a dehydration or a hypovolemic state. I told you that the loop of Henle, the lowest portion of the loop of Henle is always maximally concentrated.
Yes.
In a scenario where I have a dehydration, I have the activation of this ADH that will make the urine more concentrated as it passes through the collecting duct.
Yeah.
Yes.
In the lowest portion of the collecting duct, the urine becomes maximally concentrated because of free water reabsorption via
Yes.
ADH. So that makes the lowest portion of the collecting duct and the lowest portion of the loop of Henle maximally concentrated whenever I have a dehydrated stage or whenever I have a activation of ADH.
Yes.
Yeah.
Okay.
Yes.
In a hypervolemic state, this collecting duct is the maximally diluted, right?
Yes. Yep.
Okay. Yeah. Because you would continue like just
Yeah.
pulling out so in a
Just
maximum.
just forget the hypervolemia or hypovolemia for a second. If you
Mhm.
have ADH, you will have a reabsorption of water. You will have a maximum concentration as the urine passes through the collecting duct. If you do not have the ADH, you won't have any absorption of the water. This portion become maximally diluted. It's just the role of ADH, right? If the
Yes.
ADH is present, this portion become maximally concentrated. If the ADH is not present, this portion becomes the maximally diluted.
Yes.
And now correlate the presence of ADH and absence of ADH with the hypervolemia or the hypovolemia. Okay.
Yes.
Now, any doubt?
No, thank you. Got it. Thank you.
Okay. So that was about the DCT. Okay. Now comes the collecting tubules or the collecting ducts. It has two types of cells. Actually, three types of cells. One are the principal cells. Second are the alpha intercalated cells. And third are the beta intercalated cells. Okay. Again, you for the baseline pump, you have the sodium potassium ATPase that will again draw out three sodium and draw in two these two potassium inside the cells. Okay, you have certain channels. First, you have the water channels, and these are not the aquaporins. Okay, you have one type of channels which reabsorb the water normally. Second type of channels are the aquaporine channels. Okay, so two different type of channels are present. Then you have the potassium also. Again, just like any other of this channel, it will cause the efflux of the potassium. You have the sodium channels, and just like any other sodium channels, it will draw in the sodium. And along with the sodium, it will also draw in the water. Is that okay? Whenever you have a sodium absorption, you always has a water absorption, right?
Yes.
And those were the transporters I was talking about of the water. Okay. One type of transporters only reabsorb the water, and second type of transporters reabsorb both the water as well as the sodium.
Okay.
Okay, two type of water transporters are present. Okay, and you have the chlorine channels, you have the potassium channels also. Chlorine got reabsorbed, potassium got efflux into the lumen again. Okay, on the basolateral side, you have the sodium potassium ATPase. On the principal cells, you have two more receptors. One is the receptor for the ADS, that is a V2 receptor, function cyclic AMP. You guys remember that already. Second are the receptors for the aldosterone. Okay. Function we
Yes.
will discuss later shortly. Okay. Just know that these two receptors are present. Now you have the alpha intercalated cells. They have the hydrogen ATPase pump. Whenever the ATP is present, it will activate the pump. It will cause the efflux of the hydrogen from the cell into the lumen. Okay, so help getting rid of the acid. Whenever you have a too much of the acid, this pump got activated and it will draw out all the acid from the cells, from the body. Okay.
Yes.
Second type of pumps are the potassium hydrogen pumps that will cause the influx of the potassium and outflux of the hydrogen. These pumps are dependent upon the concentration of potassium in your body. I told you, regardless of the concentration of potassium, you will have a maximum reabsorption in the PCT, right?
Yes.
But the absorption of potassium through these channels is dependent upon the concentration of the potassium in my body. If I have a hyperkalemic state, then these pumps got inactivated. In that scenario, you won't have a reabsorption of the potassium and you won't have a secretion of H+. In a scenario where I have hypokalemia, these pumps get activated. They will reabsorb the potassium and secrete the hydrogen.
Yes.
Okay. So in scenario where you have this hypokalemia, okay, you will have a slightly, this metabolic alkalosis also because of getting rid of the H plus, right? And whenever you have the hyperkalemia, you can have a rid of this acid. Sorry, whenever you have a hyperkalemia, you will have a low secretion of this acid, so you can get a metabolic acidosis state.
Yes.
And actually, the reverse is true. Don't think it like that. The reverse is actually very much true. Whenever you have a acidemia, you will have a hyperkalemia, and whenever you have a alkalosis, you will be having a hypokalemia. Think it like that now.
Yes.
Okay. And I think after 3 pages later, you will read about this potassium shift and the causes of this hypokalemia and this hyperkalemia. And one of the cause of this hypo and the hyperkalemia is the presence of metabolic acidosis and the metabolic alkalosis. Okay. So when we discuss that, I will again refer back to here to these pumps. Okay.
Yes.
So do remember this. Now, third type cells are the beta intercalated cells. The function of one more pump is present in the alpha intercalated cells. These are the chlorine bicarbonate pump. Like I told you, they always opposite to each other. Whenever you have an influx of the chlorine, you will always have an outflux of the bicarbonate, right? Like a chloride shift.
Yes.
So that's how you will get the reabsorption of bicarbonate in the collecting tubules. Similar type of pumps are present in the beta intercalated cells, except the function of these cells is to cause the efflux of the bicarbonate into the lumen and get a reabsorption of the chlorine inside the cell. And then you have a hydrogen ATPase pump that will draw in the hydrogen inside the blood. Okay.
Okay.
Now let's discuss the function of aldosterone. Whenever the receptors got activated, then there's two things. Okay, one is the activation of the one thing in the principal cell, and that is the activation of ATPase. This ATPase got activated, it will create a concentration gradient that will cause the influx of sodium and as a result water also, right?
Yeah.
And cause the efflux of the potassium. That is the first thing. Second
Yes.
thing, it causes the activation of this hydrogen ATPase pump in the alpha intercalated cells, and as a result, you will get the efflux of this hydrogen from the cell, getting rid of acid, so you will get a metabolic alkalosis whenever you have aldosterone activation.
Yes.
And now you can again correlate that because of this aldosterone activation, I'm having a hypokalemia as well as metabolic alkalosis.
Yes.
So whenever I have alkalosis, I will always have a low potassium levels. Whenever I have a acidosis, I will always have a high potassium levels.
Yes.
Okay. Now, second are the aquaporins, and you have a receptors that are the V2 receptors for the ADH. Whenever the ADH combines with the V2 receptors, it will activate the aquaporins, and these are these hydrogen channels. Aquaporins got activated, and just like these insulin, remember what transporters for the glucose? Whenever the insulin is present, what type of transporters for the glucose influx?
GLUT2.
Yeah,
Bluetooth.
GLUT2.
GLUT2. Are you sure?
SGLT2, no?
It
SGL.
was GLUT. It was GLUT4,
GLUT-
not the GLUT2.
GLUT4. Yeah. GLUT4.
Yeah. Just like the GLUT4, whenever my insulin is present, I will get a translocation of these GLUT4 receptors on the muscle and the adipose tissue, right?
Yes.
Similarly, whenever I have a presence of this ADH, it will activate the V2 receptors, and that causes the translocation of these aquaporins on the cell surface towards the lumen side to draw in the water, because you know that this membrane is impermeable to the water. You need special transporters for the entry of water, right?
Yes.
So only when the ADH is present, I will get the reabsorption of the water. Is that okay?
Yes.
And note that this water is a free water, no sodium. While whenever you have a RAS activation, whenever you have a aldosterone, it will always causes the reabsorption of both sodium as well as water along with it. Okay.
Yes.
You have the activators of these receptors, and does anyone remember the name? Analog of my ADH?
Vasopressin.
Yeah, this is the vasopressin. Alternate name of my ADH is the vasopressin. What is the analog of this vasopressin drug?
Desmopressin?
Desmopressin, yes. So you have a desmopressin that will activate it and will cause the reabsorption of the water. Okay, I will use it in the central diabetes insipidus and in the one more thing in a childhood where I can use a desmopressin.
Bedwetting?
Bedwetting, yes. Okay,
Yes.
and now again, the inhibitors of this ADH. Remember the name? Antagonist of ADH.
Spironolactone?
Spironolactone? No. That is not for the ADH. It is for the RAS and the aldosterone. ADH inhibitors. The tolvaptan, conivaptan, all these vaptans, remember?
Yes.
So do remember all these names, very important. Prasins for the analogs and vaptans for the antagonist. Okay.
Okay.
And one more drug for the antagonist, and that is an antibiotic.
Doxycycline?
Not the doxycycline, damiclocycline. Okay, related to the this doxycycline, a tetracycline drug, which is the damiclocycline, right?
Okay.
Remember?
Yes.
So these are the antagonists. You can write it down here also. Oh, no. It's okay. It's totally okay. You're here to learn, right? I'm also having a very bad day since yesterday. So I totally understand. Okay, so you can write the names here. It will make it very lot easier while you revise this. All the antagonist and the agonist, desmopressin, all the pressins are the agonist drugs, or the all the vaptans and the damiclocycline is the antagonist drugs that act on the V2 receptors. And does anyone remember the other inhibitors of the V2 receptors? Side effects? As a we have discussed in the psychiatry part. Lithium, remember?
Yeah.
Lithium is also an inhibitor of the V2 receptors. Okay, so that was about the V2. Any doubt on the ADH?
No.
No, thanks.
Thank you.
Okay. Now you have second is the aldosterone. Okay, that acts on the receptor, causing the activation of sodium potassium ATPase, potassium pumps, sodium pumps, and the hydrogen ATPase pumps. You can either inhibit these sodium pumps or you can directly inhibit the receptors for the aldosterone. The receptor inhibitors are the spironolactone and the aplepenon, and the inhibitors of the sodium pumps are the amiloride and the triamterene. Okay,
Yes.
so do remember them also. Okay, we will discuss certain diseases in which you're having a hyperactivation of the sodium channels or the hyperactivation of these receptors. So looking on the pathology, if you're having a hyperactivation of these receptors, you can use spironolactone or the aplepenon. If you're having a hyperactivation of sodium channels only, then you will give the patient amiloride and triamterene. Okay, so depending upon the diseases, you can either use the spironolactone or you can use the amiloride. So do remember that also. In the absence of, yeah,
When we use amiloride.
whenever you have a hyperactivation of sodium, we will discuss the disease later.
Okay.
I think it's in the next page.
Okay.
Yeah, it's in the next page. Okay, where you have a Riddle syndrome, remember?
Yeah. Yeah.
And the Riddle syndrome, you're having a too much activation of these sodium channels because of a gain in function mutation. And as a result, for a treatment, I have to give the patient triamterene or the amiloride. Okay. In
Okay.
syndrome of apparent mineralocorticoid axis, you're having a too much activation of these receptors. Okay, and as a result, the treatment is the spironolactone and the aplepenon. Okay,
Okay.
so just keep that in mind for the next page. In the absence of ADH, the collecting duct is the maximally diluted part. In the presence of ADH, the collecting duct is the maximally concentrated segment. Okay. In the hyperkalemia, it will cause a secretion of all this potassium, and the potassium secretion can even reach to 110%. If you have 100% filtration of the potassium in my from the glomeruli into my PCT, I can have a 110% secretion in the collecting duct whenever I have a hyperkalemia. See how much amount of this potassium got secreted. 110% is just too much, right?
Yes.
Okay.
Okay.
Let us
Yes.
suppose if I have a concentration of 100 milligram in case of my PCT, then I can have a 110 milligram concentration in the collecting duct in scenario where I have the hyperkalemia. Okay, because of the secretion of all this potassium from these cells, these principal cells. Okay, and the inhibition of these pumps, the potassium and the hydrogen pumps in the alpha intercalated cells. Do remember that. And I think collecting tubules, sodium, aldosterons, and yeah, everything is covered. Any doubt on the collecting duct?
No, thank you.
Okay, so if I want to draw some, let me draw a graph for you. Let's divide the nephron portion first. Okay, this portion corresponds to the PCT. This portion up to here corresponds to the descending loop of Henle. This portion corresponds to the ascending loop of Henle. Okay,
Yes.
and then you have the collecting duct. Let's draw, what are the concentration of all these solutes you will get as these solutes passes through these different portions of the nephron. Okay, let it be a one concentration. This is the line where the solute concentration is just as equal to the water. Okay, whenever you have the filtration of any solute by the GFR, okay, in the PCT the concentration of this solute is this. Let's say it is 1, the filtration load. Okay,
Yes.
now as whenever the water get reabsorbed, okay, either the water get reabsorbed or the substance is secreted, can I have a more concentration of this of that substance? I will have a rise in concentration of that substance, right?
Yes. Yeah.
It could be either due to the free water reabsorption or it could be due to the secretion of that substance, right?
Yes.
If I have a less water reabsorption, okay, and more, if I have a less water reabsorption, okay, and more reabsorption at that substance, I will get a low concentration of that substance. If I have more free water or
Yes.
more reabsorption of that substance, then ultimately the concentration of that substance will decrease,
Yes.
right? Actually, this one corresponds to the tubular fluid concentration of that substance divided by the plasma concentration of that substance. And you know that whenever that substance got filtered from my GFR, the tubular concentration of that substance will always be equal to the plasma concentration, right? Because it is clearly filtered. If I have a 10 milligram per deciliter concentration of that substance in the plasma, then I will get a 10 milliliter per deciliter concentration of that substance in the tubular fluid, in the hyperfiltrate, in the ultrafiltrate, right?
Yes.
So that makes it a 1, right? As this solute passes, when the water get reabsorbed, I will have a more concentration of this substance in the tubules when the water got reabsorbed.
Yes.
So the ratio will increase. I will get a ratio more than 1 if I get a more reabsorption of the water or less concentration of water, right?
Yes.
Similarly, if I secrete this substance in the tubule, then I can have a more concentration of this substance in the tubule than the plasma. Again, I will get a ratio more than 1.
Yes.
If I have more water than the substance as it passes through this portions, I will have a less concentration of this substance than the plasma. That means a ratio less than 1.
Yes.
Similarly, if the substance absorbs more than the water, then I can have a low concentration of this substance in the tubule than the plasma. Again, a low concentration than the 1.
Yes.
Now let's talk about the glucose. This is the PCT. This is the descending loop of Henle. This is the ascending loop of Henle. Okay, this is the DCT. And this is the collecting duct. Okay, this is the collecting duct. Now let's talk about the glucose first. You guys already know that the glucose got 100% absorbed in the PCT, right? In a normal this person, right? In a
Yes.
normal person, glucose is getting 100% absorbed, more than the water. Water is only 80% absorbed, but the glucose is 100% absorbed. So what's gonna happen to my glucose ratio, the tubular glucose concentration and the plasma concentration of the glucose? What's gonna happen to the graph? Does it go upward or downward?
Downward because you're being reabsorbed.
Yeah, exactly. And as a result, at the end of the PCT, all of the glucose got 100% absorbed.
Yes.
Right? This is a graph for my glucose. What about the amino acids?
They should also be reabsorbed.
Yeah, they will also get absorbed, and you will get a similar kind of a graph like that of glucose. This is for the amino acids. Okay, what about the sodium?
Sodium is
I'm getting a 80% of the absorption of sodium and the 80% absorption of the water. Then what's going to happen to my sodium levels as it passes through the PCT?
about even.
Yeah, it will remain constant near the 1. Okay, this is the sodium levels near the 1. Okay.
Yeah.
Same thing goes for the chlorine. Their level also remain near 7. Okay. What about the para-amino hippuric acid? It
Could you
got
please
freely
repeat
filtered
for
first.
sodium?
Yeah.
Could you please repeat for sodium? I'm not getting.
See, whenever you have an absorption of sodium, you will also have an absorption of water along with it, right? It's a general rule, right?
Yeah.
Sodium always brings the water with it. So whenever I have absorption of sodium, I will also have absorption of water. So that makes the concentration of water and that makes the concentration of sodium in that fluid always nearly equals to 1.
Okay.
Yes.
Right? So it will always remains
Thank
1.
you.
Similar thing goes for
Thank
the
you.
chlorine also. Chlorine and sodium, they always remains near the 1.
Yes.
Okay.
Actually, this chlorine is little bit difficult. Initially, it got rise slightly, but then later it will catch up. Okay. The chlorine initially rises, but then later it will catch up. Okay.
Okay.
What about the potassium? Again, it is absorbing nearly 65%. So again, remaining little above the line. Okay. Sodium below the line and potassium above the line. Okay. Chlorine more above the line. But later, all of the sodium, potassium, and chlorine, they will catch up in the later portions of the tubule near the 1. Okay.
Yes.
Now, what about the para-amino hippuric acid? I told you, you have 2 ways. One is the hyperfiltration or the ultrafiltration, GFR. In that case, you will get a normal concentration, which is 1, because it will always be fully filtered, right? 20%. And the remaining 80% will be secreted.
Yeah.
So as this para-amino hippuric acid passes through the proximal convoluted tubule, the concentration, because water is reabsorbing in the PCT, but the para-amino hippuric acid, it cannot be reabsorbed, right?
Yes.
Yeah.
So that will increase the concentration of PAH as it passes through the PCT.
Okay.
Okay. What about
Okay.
the urea? Urea is slightly absorbed in the PCT. Okay. So it will have a line which is lower than that of my pH, and it somewhat lies here. Yeah, this is my urea. So this is the para-aminohippuric acid. This is the urea. This is the chlorine. This is the potassium. This is the sodium. Is that okay up to here?
Yes.
Yeah.
What about the creatinine? Does this line lie above the urea or below the urea? Creatinine?
A little higher
Little higher.
Higher
Why?
than urea.
Why?
because creatinine it is it's secreted as well.
Yeah, because it is secreted in the tubule. So it will be higher than that of urea. Urea is only getting reabsorbed. But the creatinine, it is being secreted along with the this ultrafiltration, right? So there lies the creatinine. What about the inulin? Higher or lower than this creatinine? Inulin,
Higher than
higher or lower?
higher than
Higher than the creatinine, right?
Inulin is a little lower. I thought
Lower, exactly. It is lower than the creatinine. Why? Because it can neither be reabsorbed nor be secreted, right? Why the creatinine is being secreted. So it has more concentration in the PCT than the inulin. Is that okay?
Yeah. Yes.
So that
yes.
kind of a picture you will see as all these substances passes through the PCT. This is the PCT limit. Okay, the sodium will always follow the water. Concentration nearly remains 1. Chlorine initially increases, then catch up with the sodium. Potassium a little higher, but a below than the chlorine. Urea, because it is being reabsorbed, so below the inulin. Inulin can neither be reabsorbed nor be secreted, so little higher than the urea. This creatinine, because it is slightly secreted, so little higher than the inulin. Para-aminohippuric acid cannot be reabsorbed, but can be secreted. Okay, so a little higher than the creatinine. While glucose and amino acids completely reabsorbed more than the water, so a low concentration in the PCT. Right?
Yes.
Yeah.
Now, what about the descending loop of Henle? What's gonna happen to here? In the descending loop of Henle, I'm having a free water reabsorption, just of water, no other solute. So what about the concentration of all these solutes? All the sodium, all the chlorine, potassium, and all of them. What's gonna happen to them? Will they rise or will they fall?
Fall.
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 They will fall, right? Their concentration will fall.
Yes, because you're adding more water, and so then
Water.
the concentration.
I'm not adding more water. I'm reabsorbing the water from the tubule. See, this is a picture of tubule, not the blood. I'm absorbing the water from my tubules. So what's gonna happen to the concentration of all these solutes in the tubule? Will it
Increase.
rise or will it fall?
Increased.
Rise.
Increase. It will rise, right?
Yes.
Because either you can secrete them or you can freely reabsorb the water. Okay, both of these scenarios will increase the concentration of these solutes.
Yes.
Just look at this formula, the tubular concentration by the plasma concentration. If I'm absorbing too much of the water, I will have a low concentration of water in the tubules, and that makes the concentration of all these substances go up more than the plasma concentration. So a ratio more than 1 always, right?
Yeah.
Okay, so now as these solutes enter into the enters into descending loop of Henle, the concentration will start rising rapidly. Okay, all of them will go up. All of them will go up, right?
Yes.
Including my sodium, chlorine, and potassium, they also go up. Okay.
Yes.
At the point where this where this descending loop of Henle ends, the concentration of all these substances become maximum, like I told you. Right?
Okay.
Yes.
All the substances concentration become maximum in the lowest portion of the descending loop of Henle. Is that okay?
Yes.
Now, what happens in the ascending loop of Henle? You have some transporters, because this portion is impermeable to my water. I cannot have the water reabsorption, but I can have the absorption of these solutes. So that will decrease the concentration of some of the solutes, right? For example, what about the sodium and chlorine? They will again attain a concentration lower than the water itself, right? And as they reaches the this DCT, the concentration is already very much minimal, right?
Yes.
That's about my sodium, chlorine, and potassium. Is that okay? The minimal concentration is found in the DCT because they're being reabsorbed, right? But the water is already present in the same amount, right?
Yes.
Similarly, this urea, okay, it will get flattened like that, okay, because it's neither reabsorbed nor secreted. Water is already in the same amount. So that will make a very constant value up to the DCT. Same thing goes for my this inulin. It will become very much constant because it neither can be reabsorbed nor can be secreted. Okay. Creatinine is again become a slightly rising, slightly more than the in this inulin, of course, because it is slightly being secreted, right? You have this para-aminohippuric acid. This again become a slightly increase, not as like in that of the descending loop of Henle. Okay. The fastest increase in the concentration is found in the DCT, right? While in the fastest increase in the concentration found in the descending loop of Henle, while in the other portions you will have a slightly increase in concentrations only, right?
Yes.
Now, what about the collecting duct? It depends upon the DCT and the collecting duct. Now, these portions are totally dependent upon the concentration of different solutes in your body. Okay. If let us suppose you're having a patient who is having a hyperkalemia, then what's going to happen to the potassium concentration in the DCT and in the collecting duct? What's going to happen to it? If I'm having a patient of hyperkalemia,
Decreased here.
yeah, what?
Can you even absorb potassium in the distal collecting tubia?
Yeah, you tell me. You have studied this diagram already. You tell me if I'm a patient who is having a hyperkalemia, what's going to happen to the potassium? These channels, will they secrete potassium or will they absorb potassium in a patient with hyperkalemia?
You would want to excrete it out.
Yeah, I want to excrete it out, right? So I want more concentration of potassium in the lumen.
Yeah.
So
Secrete.
that will increase the concentration of potassium, and I told you it will reaches to 110%.
Yes.
So in a hyperkalemic state, I can have a rapid high concentration of potassium as my fluid passes through the DCT and the collecting duct. Is that okay?
Yes.
Now, what about the water? Let us suppose I'm having a patient who is in a hypervolemic state. Okay, now can I have a reabsorption of water in the collecting duct? If I do not have any ADH, can I have this reabsorption of water in the collecting duct without ADH? Free
No.
water I'm talking about. No.
No.
In that case, the concentration of all these solutes will decrease now because of presence of free water. The concentration of all these solutes will start decreasing, and in the collecting duct, it become a maximally diluted portion because of presence of free water.
Yes.
Okay.
Yes. Yes.
Now, what about if I'm a patient who is having dehydration? That means I'm having a high ADH in my collecting duct. What's going to happen to my water?
Increase.
Increase what? Excretion.
Reabsorbing water into
Yeah,
your
it
body.
will reabsorb the water, right? So what's going to happen to the concentration of all these substances?
They're going to increase.
Yeah, in dehydration state, the concentration of all these substances again will be increased, just like the descending loop of Henle, right? Because whenever you have a dehydration, this portion becomes just like the descending loop of Henle, right?
Yes.
So that kind of a graph you will see as all these solutes passes through the different portions of the nephron. That kind of a picture you will see. Okay, do remember what this one is. It is the concentration of that substance in the tubule divided by the concentration of that substance in the PCT, in the plasma. Whenever they got a hyperfiltrated, okay, they will found in this portion. It will always be equals to 1 because all of the substances got freely filtered, right? In accordance to their concentration gradient. As the substances passes through the PCT, the fluid always remains the isotonic, then become hypertonic, then become hypotonic. Dependent upon the water status, the fluid either can become more hypotonic. Okay, if you're having a patient who is dehydrated, then this part become hyper concentrated or hypertonic. Okay,
Yes.
Yeah.
any doubt on this graph, please ask. Step 1 will give you this graph and they will ask you, what kind of a graph you will get in the sodium, potassium and other things, right? So you need to understand this graph very well.
No, I think I'm
Just
okay.
note, yeah, just note the concentration of a substance um, in a fluid. Okay, it dependent upon two things. Okay, the amount of the substance, and second is the water. If you have a low water and high amount of that substance, you will have a high concentration in the solution, right? If you have a low water, if you have a very high water and low amount of substance in the solution, you will have a low concentration, right? So it's all relative. Similarly, in my tubules, if I have low water and more amount of substance, I will have a high concentration. If I have high water and low amount of substance, I will have a low concentration.
Yes.
Okay, so
Yes.
please respond everyone if anyone needs any more clarification on this topic.
No, I think I'm okay.
No, thank you.
Okay, now that was all on this page. So in the absence of ADH, the lowest part of this loop of Henle is already very much concentrated. In the presence of ADH, the collecting duct becomes the maximally concentrated part, just like the loop of Henle, and DCT is already very much diluted. Water reabsorption doesn't matter. It, it doesn't matter whatever the concentration of whatever the status of your body volume is, you will always have a highest water reabsorption in the PCT. Okay, water can freely reabsorb up to the descending loop of Henle. From the ascending loop of Henle up to the collecting duct, water cannot be freely absorbed. It needs some transporters because the membranes are always impermeable to the water. Okay,
Yes.
now you have certain defects in the renal tubules, and one is the Fanconi syndrome. It is kind of a generalized defect in the PCT. See, all these defects are rearranged in the order of the portions of the tubules. Okay, first you have the PCT, then the loop of Henle, then the DCT, and then the collecting duct. Okay, so even if you forget the name, just know that these are all arranged in the sequence of the different portions of the nephron. So one is the Fanconi syndrome. Okay, it is a defect in the PCT. PCT loses its ability to reabsorb any of the solute, and as a result, you will have a loss of sodium, loss of amino acids, loss of glucose, loss of phosphate, loss of everything So it is a generalized reabsorption defect. You will have in the PCT, you will have an increased excretion of amino acids, glucose, bicarbonate, phosphate, and all other substances which got reabsorbed in the PCT. Okay, because you're having a loss of bicarbonate. I told you bicarbonate with this hydrogen ions combined to form this carbonic and this acid, and then it got reabsorbed, and and like that you will have a reabsorption of the bicarbonate. In
Yes.
case of my this syndrome, you will have a loss of bicarbonate, and that causes the metabolic acidosis,
Yes.
right? You will
Yes.
have a hypophosphatemia because of loss of this phosphate. Okay, loss of phosphate can also lead to rickets, osteopenia, right? A severe rickets in the child. Bone pain will be the presenting complaint of any patient, adult specifically. Okay, if you encounter a patient with adult who are having a Fanconi syndrome, they will have a bone pain because of loss of this phosphate, because the inorganic portion requires both the calcium and the phosphate, right?
Yes.
So that happens because of this hypophosphatemia, because of this loss of phosphate. You will get the stones also because of loss of this calcium, loss of phosphate. You will get the calcium phosphate stones, right? Renal stones are the presenting complaint also. Because of presence of glucose in the tubules, in the urine, you will also get the recurrent UTIs, right?
Yes.
How you can make a diagnosis of the patient? You need to check for the urine. Okay, if you find the amino acids in the urine, it is always pathological, because under a normal circumstances you will always have 100% reabsorption of the amino acids, right?
Yeah.
Either you have a too much amino acids in your blood, like in case of the multiple myeloma, for example, you have a Ig light chain, right? That can cause the amino acid presence in the urine. But if the patient is not having any multiple myeloma or having a normal protein levels in the body, then they are having these amino acids in the urine. That means it is always pathological. Similarly, if you're having a normal blood glucose, and even after a presence of normal blood glucose, you're having a glucosuria, that will make you suspicious for the diagnosis of Fanconi syndrome, right?
Yes.
So that's how you will diagnose this condition, by checking the levels of all these substances in the blood first. You will find either a low concentration of these substances in the blood or a normal concentration. Looking in the urine, you will find a very high concentration of all these substances. Then you know that the patient is having a Fanconi syndrome. Causes, the GI causes includes the Wilson's disease, tyrosinemia. Okay, in the biochemistry, the glycogen storage diseases can cause the Fanconi syndrome. Ischemia, of course, of the kidney can cause it whenever you have a ischemia. I told you in the medulla you have this hypoxic part, and the highest oxygen utilizing segment of the nephron is the PCT and the ascending limb of loop of Henle. Okay.
Okay.
So whenever you have a hypoxia, the first portion that dies is the PCT. And whenever this portion got died, it cannot reabsorb anything. You will get a Fanconi syndrome again, right?
Yes.
So ischemia can do that. Multiple myeloma, where you have a damage of the kidney because of presence of all these proteins, right? Antibodies and all these things, you will have a damage of the kidney, you will get a renal failure, I told you, right?
Yes.
So in the multiple myeloma, you can get a Fanconi syndrome. Certain anti-cancer drugs like the ifosfamide, cisplatin, carboplatin, lead, okay, they can cause the Fanconi syndrome. So remember the GI causes, that is a Wilson's disease. Remember the biochemistry, glycogen storage diseases, okay, the hemonc, that is a lead poisoning, and the ifosfamide and the multiple myeloma. Remember 3 chapters, okay, you will get all these causes. So just 3 chapters, okay, GIT, biochemistry, and the hemonc. That's how you can learn all the causes of the Fanconi syndrome. Any doubt, please ask.
No, thank you.
Then you have, oh, okay, now see, all of these syndromes are arranged in the alphabetical orders now, okay, and also in the order of sequence of all these nephrons part you will encounter. So even if you forget the name, just know B, that means it is for the LOS, the most proximal segment. Then G, after the B in the alphabetical series, it will be the DCT. Then L, it will be for the collecting duct, and then S, it will be for the collecting duct again. Okay. So first you have the Bartter syndrome, and whenever you heard the Bartter syndrome, okay, just remember the loop diuretics. All these symptoms you will get in the Bartter syndrome is just like in the loop diuretics, because in Bartter syndrome you are having an inactivation of the sodium potassium chloride channels, the same channels which your this loop diuretics inhibits. So metabolic alkalosis, hypokalemia, hypercalciuria, diuresis, dehydration, right? All of these things similar to that of loop diuretics. Okay. You will also get the renal stones, hypocalcemia will be there, hypercalciuria will be there, hypokalemia will be there, right? Is that okay?
Yeah.
So whenever you hear this Bartter syndrome, think about the loop diuretics. Similarly, whenever you hear the Gentleman syndrome, think about the thiazide diuretics, which inhibits the sodium chloride channels in the DCT. And as a result, you will have a metabolic alkalosis, hypomagnesemia, hypocalciuria, because you have a reabsorption of the calcium. I told you the thiazide the diuretics can do that. You will have also the hypokalemia, right? All the side effects of the thiazide diuretics, right? Gentleman syndrome. Okay.
Yes.
So whenever you heard about the Gentleman syndrome, think about the thiazide diuretics all the time. Every side effect, every effect is similar to that of the thiazide diuretics. Low calcium in the urine, high calcium in the serum, metabolic alkalosis, loss of sodium, magnesium, potassium in the serum, right?
Yes.
Then you have the Little syndrome. Okay, in the Little syndrome, I told you have a gain of function mutation in the sodium channels, and as a result, you will have a more sodium reabsorption, and that will again do the reabsorption of water. So effect is just like the hyperaldosterone effects, because again the aldosterone is working, by acting on the sodium channels, right? By activating the sodium channels, right?
Yes.
So effect is almost similar to that of hyperaldosteronism. You will get a metabolic alkalosis, hypokalemia, hypertension, but you will have a low aldosterone level, you will have a low RAS, renin angiotensin aldosterone system will be inhibited in the Little syndrome. And please note, it is the activation of these sodium channels. So treatment includes inhibiting the sodium channels by giving the patient amiloride or trampoline. Is that okay?
Yes.
Again, you have the syndrome of apparent mineralocorticoid axis. In that case, you're having an inactivation of the 11 beta HSD, which is an enzyme that degrades your cortisol into the cortisone. If you go back into the endocrine part, we have discussed about this enzyme, how it converts the cortisol into the cortisone. If this enzyme is not present, in that case, you will not have any conversion of the cortisol, right?
Yes.
Okay, so now in that case, you will have a high cortisol levels, and that causes the activation of these adrenal receptors, aldosterone receptors. Sorry, it will activate the aldosterone receptors, because you know that the cortisol also had the mineralocorticoid function, right? Go back to the
Yes.
Cushing syndrome. I told you that the cortisol also has the activation of the receptors, these mineralocorticoid receptors. So it will cause the activation of mineralocorticoid receptors, and that causes the hyperaldosteronism like symptoms. Symptoms will be exactly similar to that of Liddle syndrome. You will get a metabolic alkalosis, hypokalemia, hypertension, but you will have a low aldosterone levels again. Right? You will again
Yes.
find a high concentration of cortisol. Treatment includes inhibiting the receptors for the aldosterone, and that can be given, that can be achieved by giving the patient spironolactone, aplapenone, right?
Yes.
You can give the patient potassium sparing diuretics, that are the spironolactone and aplapenol. Okay.
Yes.
So any doubt on any of this syndrome?
No. Thank you.
We have discussed that already, right? In the previous page, I told you about this tubular fluid concentration divided by the plasma concentration. If it is 1, that means you have a same concentration of the tubular fluid as that of plasma fluid, right? Talking about the individual concentration. Okay,
Yes.
if we have, let's talk about the pH. Whenever the pH freely filtered, the concentration of the pH in the tubular fluid will be exactly similar to that of plasma. And as a result, you will get a ratio of 1. As the water is reabsorbed while passing through the PCT, and the PAH is secreted into the PCT as the fluid passes, you will get a more concentration of the PAH like that. You will have an inulin which can neither be secreted nor be absorbed. Okay, so the concentration because of water is reabsorbing, and if you have a low water or high amount of solute, you will always have a high concentration of that solute in the solution, right? So consider it a solution. You will have a more concentration of this solute as it passes through the PCT. Creatine, because it is slightly secreted, you will have a more concentration than the inulin. Urea, because it is slightly reabsorbed, you will have a less concentration than that of inulin and creatinine. Chlorine, initially it will rise, but then it will achieve a normal level, that of sodium 1. Okay. Potassium a little higher than the sodium because it is only 65% reabsorbed, while sodium can reabsorb up to 80%, exactly to that of water, because whenever sodium got reabsorbed, water got reabsorbed along with that too, right?
Yes.
So sodium exactly at 1, potassium a little higher, bicarbonate, amino acids, glucose, almost 100% of them got reabsorbed in the PCT.
Okay.
Yes.
So a ratio more than 1 whenever the solute is reabsorbed less quickly than the water. That means that means the water is being reabsorbed more than that of solution, than that of solute. You will get a concentration, this ratio less than 1 whenever the solute reabsorbs more than the water. So that will make a concentration of that solute less in that solution, less than 1. Okay.
Okay.
That kind of a graph you will see as, this graph is only for the PCT, and this graph is all for the loop of Henle, DCT, and the collecting duct. As the glucose is completely reabsorbed, amino acids are completely reabsorbed, sodium, chlorine, and potassium nearly equals to 1. Okay, in the loop of Henle, as the free water reabsorbed, that will again rise the concentration of the sodium. Okay, a peak level is achieved in the lowest portion of the loop of Henle. Then comes the ascending portion where the sodium and potassium and the chlorine got reabsorbed, but not the water. So the concentration of these substances again decreased. In the DCT, the concentration again start rising because you have a water reabsorption, right, in the dehydrating stage. So the concentration of these substances will rise. It depends upon the state of your water. If you're having a hypervolemia, the concentration again fall. If you're having a dehydration, the concentration will rise. Okay. pH, because it is continuously being secreted throughout all these parts, as you can see, you will have a high concentration always. The concentration of this pH is always increasing throughout all the segments. Okay.
Yes.
Then comes the creatinine and the inulin. Okay, they will achieve a very constant level. Okay, up to the loop of Henle, descending loop of Henle, the concentration achieve maximum. Then a constant level is there. Okay, in a dehydrated stage, you will have a reabsorption of all this water. So again, the concentration of creatinine and the inulin will rise. Similar thing goes for the urea. Okay.
Okay.
So any doubt on this page?
No, thank you.
Now comes the RAS, and we discuss this after a short break. Okay.
Sure. Thank you.
So far we have discussed. Yeah, so far we have discussed all the pictures of this PCT you will see. Okay, the concentration changes of all the solutes that you will see when the fluid or this filtrate passes through the different portions of my nephron. Okay, and let's go back and remind ourselves one important concept again, and that was this angiotensin 2. Okay, I told you that this angiotensin 2 acts on the efferent arteriole, and the prostaglandins act on the afferent arterioles. Whenever the angiotensin 2 is present, it will cause the constriction of this efferent arteriole, causing an increase in the hydrostatic pressure that will and that will cause more filtration, right? You will have a more GFR for a given plasma flow, a normal blood flow, but because you're having a constriction of this efferent arteriole, the blood flow to this portion will be decreased, and that's because of a decrease in the, just give me a second. Yeah. And that's because of a decrease in the pressure gradient here to here, right? Pressure gradient from afferent arteriole to the efferent arteriole, you're having a decrease in the renal plasma flow. Okay, because of an increase in the hydrostatic pressure in this portion, you're gonna have an increase in the filtration, so more GFR. Okay, so as a result, you will have a more filtration fraction. But whenever you dilate this afferent arteriole, you will have a more blood flow, okay, a more GFR, but a normal filtration fraction, right? A normal filtration fraction will be present whenever you dilate or constrict the afferent arteriole, but a change in the filtration fraction is present whenever you constrict or dilate the efferent arteriole, right? And yeah, so the ACE inhibitors inhibit the angiotensin 2, decreasing the load of this pressure on the glomeruli, preventing your kidney from getting damaged. In a dehydration, you need the prostaglandins to increase the blood flow to the kidney to prevent the hypoxia and the kidney damage in a hypoxic state, or you can say in a shock stage, right? NSAIDs are contraindicated, right? So with these things in mind, let's discuss the RAS system. Okay, so for the RAS, you need to know that 3-4 cells are involved. Okay, the one are the modification of the smooth muscles of the afferent arteriole. You call them what cells? The modifications of my afferent arterioles that takes part in the RAS system, what these cells are called?
Macular cells.
Not the macular cells, macular cells,
JG cells.
the JG cells, juxtaglomerular cells, right? The modification of my DCT are the macular cells. Okay, so the JG cells, macular cells, and some interstitial or the mesangial cells, they forms this RAS system. Okay, the renin angiotensin aldosterone system. Okay, now first thing you need to know, what are the factors that can activate my renin? Okay, that will make these JG cells secrete the renin. The first thing is the renal perfusion pressure. Okay, whenever you have a low blood flow to the kidney, that means a decrease in the renal perfusion pressure. Okay, that will cause the activation of the renal this baroreceptors. Okay, the baroreceptors got activated and they will activate the RAS. Okay, and whenever the RAS got activated, you will have a more filtration fraction, you will have a more renal blood flow. That is the first thing. Okay, the low BP. Second is the you must know that these baroreceptors are present in the afferent arterioles. Okay, so the pressure is sensed by the baroreceptors present in the afferent arterioles, and then they will activate the JG cells to secrete the renin. Second thing is the sodium delivery. Okay, and the sodium delivery is sensed by the macular cells in the DCT. Whenever you have a low sodium delivery in the DCT, okay, that means the macular cells will activate my these JG cells to secrete the renin, and so thus you will have a more sodium concentration, right? So a decrease in the sodium delivery always activates the RAS. And the third is the sympathetic tone. Whenever you have a low blood pressure, whenever you are in a hypoxic state, whenever you're in a shock state, right? Whenever you have a decreased blood flow, that will cause the activation of my sympathetic system, and you have a beta receptors on the JG cells. These beta receptors got activated and they will activate the JG cells to secrete the renin. So for the baroreceptors, afferent arterioles, okay, for the sodium delivery, macular cells, for the beta receptors, JG cells. These are the 3 cells and 3 different ways to activate the RAS system. Any doubt?
No, thank you.
Okay, now see, when the RAS got activated, it will go to the liver, and in the liver, it will cause the secretion of the angiotensinogen. Okay, angiotensinogen will be converted into the angiotensin 1 in the presence of renin. Okay, and that is the sole function of this renin, to activate the angiotensin 1. Now, this angiotensin 1 goes to your lungs via veins, pulmonary veins. Okay, from pulmonary veins, you have the ACE enzyme, the angiotensin converting enzyme present in the pulmonary veins in the endothelium part. Okay, and when the blood flows from pulmonary veins to the pulmonary artery, all of the angiotensin 1 will be converted into the angiotensin 2. And this angiotensin 2 will enter into the left side of your heart and then to the systemic circulation. From systemic circulation, it first go to your brain, to the hypothalamus, and activates the thirst center. So you will drink more water, right? Again, in the pituitary, it will activate the RAS. It will, not the RAS, I'm sorry about that. In the pituitary, it will cause the secretion of the ADH. Okay, so two functions in the brain. One is the hypothalamus, activate the thrust centers. Second is the release of ADH from the posterior pituitary. It will go to your suprarenal glands, the adrenal glands, and from the adrenal glands, you have the release of aldosterone there. And does anyone remember what cell secretes the aldosterone?
In principle,
Principal cells? No, I'm not asking about where this aldosterone acts. I'm asking where does this aldosterone got secreted from? What cell
adrenal,
secretes the aldosterone?
adrenal.
Zona glomerulosa cells, right?
Yeah. Sonography.
Yeah. So the angiotensin 2 goes to the zona glomerulosa cells, and there it will secrete the aldosterone, right? That is again another function on the suprarenal glands. In the kidney, it has multiple functions. One is the activation of the sodium hydrogen pumps. Okay, and as a result, you will have a more absorption of sodium, right? In the PCT cells, you will have a more absorption of sodium, bicarbonate, and water, right? In the collecting duct, it will act to the aldosterone receptors, activating the sodium channels, activating the hydrogen potassium pumps, activating the potassium pumps, right?
Yes.
Okay, so in the PCT, it will be increasing the reabsorption of the water. Okay, in the collecting duct, it will be causing more sodium reabsorption, more water reabsorption, secretion of my potassium. Okay, and reabsorption of my bicarbonate again. Okay, that is a function of aldosterone, right? I'm sorry, not the angiotensin, but the function of aldosterone. Okay, the angiotensin, it will activate the PCT, causing more absorption of the sodium only, right? Then angiotensin goes to the efferent arteriole, and I told you in the efferent arteriole, it will cause the constriction, and whenever the constriction happen, it will increase the filtration fraction. Why this filtration fraction is increasing? Why more filtration after constricting the this efferent arterioles? Why more filtration?
Increased hydrostatic.
Yeah, exactly. Increase in the hydrostatic pressure in the kidneys, right? And that will increase the filtration of the fluid. And when the filtration is increased, then with the same amount of blood, I will get more filtration. That means a more filtration fraction. And that will preserves the GFR whenever the renal blood flow decreases. Okay. Angiotensin receptors are also found on the blood vessels. Okay. And in the blood vessels, the angiotensin receptors causes the vasoconstriction, and that rises the blood pressure. So in the brain, it will cause the activation of thirst centers and the release of ADH. In the suprarenal glands, it will secrete the aldosterone. In the kidneys, it will act on the PCT to cause a more absorption of sodium. Okay. In the efferent arterioles, it will cause the constriction, and so does an increase in the filtration fraction. In the angiotensin, in the blood vessel, in a systemic circulation, it will cause the vasoconstriction, so does increasing the blood pressure. That is the function of my angiotensin 2. Is that okay?
Yes.
Third is the aldosterone. Now let's talk about the aldosterone. So you have two ways by which you can activate the aldosterone. One is, of course, the RAS. Okay. And these three ways, the low BP, low sodium delivery, high sympathetic tone, that can cause activation of aldosterone via RAS pathway. And second is the potassium levels. Whenever you're having a hyperkalemia, more potassium level, it will cause the activation of aldosterone directly. And because you guys already know that the function of this aldosterone is to cause the excretion of my potassium, right?
Yes.
So one thing is the RAS, that means this angiotensin 2, and second thing is the potassium directly can activate the this aldosterone secretion. When the aldosterone got activated, it does two things. In the principal cells, okay, it will cause the reabsorption of the sodium and the potassium secretion via their respective channels. In the alpha intercalated cells, it will cause the activation of hydrogen ATPase pump. So the hydrogen will be secreted in the tubules. Okay.
Yes.
Now let's talk about the ADH. What is the function of ADH? You know that it has a V2 receptors. And how does this V2 receptors work?
Water absorption.
I mean, the signaling pathway of my V2 receptors. Signaling pathway for my V2 receptors. No one? The cyclic AMP, right?
Yeah, cyclic AMP. Yeah.
And for the V1, what pathway? IP3DAG. Remember?
Yeah.
So IP3DAG for the V1 and cyclic AMP for the V2. V2 receptors are found in the collecting duct. In the collecting duct, see, you have two portions of the collecting duct. One that lies in the cortex and the second one that lies in the medulla. And you guys already know that in my kidney, the medulla is the concentrated segment in the or the part of my kidney, right? It has a very high concentration of all these solutes. Okay.
Yes.
So see, two things gonna happen in the cortex portion of my collecting duct. With the activation of these aquaporins via ADH, I will have a free water reabsorption, just the water. Okay. Then in the medulla, along with the water reabsorption, I also have the urea absorption. Because with the absorption of urea, I will have a more concentration in the medulla, and so does more water will be reabsorbed. Are you getting my point?
Yes.
Two things, one in the cortex and one in the medulla. In the cortex, whenever the ADH is there, it will cause the reabsorption of just the water, nothing else. But in the medulla, to increase the concentration gradient for my water reabsorption, along with the water, ADH also causes the reabsorption of urea. And that causes high uric levels, okay, this BUN levels, whenever I have a more ADH, okay.
Okay.
Now the times of clinical correlations. You guys already know that in a pre-renal azotemia, you have a high blood urea nitrogen levels, right? More than, I think, 15,
Yes.
right? Why is that so? Because whenever you have a pre-renal azotemia, the causes always include a decrease in the blood flow to the urine, a decrease
Yes.
in the blood volume, right? That could be sensed by the SARA system and other systems, and that will activate the ADH. And when the ADH got activated, then it will always causes the reabsorption of all the urea,
Yes.
and that increases the BUN levels whenever you have a pre-renal azotemia. Okay, whenever you have a kidney dysfunction, intrarenal azotemia, or an intrinsic dysfunction of the kidney, you will have a loss of function of this ADH. In that case, ADH cannot cause the reabsorption of all this urea in the collecting duct, and as a result, you have a low BUN and this ratio, okay, less than 15, I think, right?
Yes.
So it's all about the ADH. Whenever you have a high ADH, dehydration, you will always have a high blood urea nitrogen. Whenever you have a low ADH or infunctionable ADH, you will have a low blood urea nitrogen. Any doubt?
No, thank you.
So these are the different hormones that are that takes part in the RAS system. Other counter-regulatory hormones includes the ANP and the BNP, and you guys already know where does these hormones secreted from. What cells secrete the ANP and BNP?
Heart cell?
Heart cells, yeah, myocytes, right? The atria secreting the ANP and the ventricles secreting the BNPs, right?
Yes.
Now, see, whenever you have a high volume, okay, or you have a too much activation of RAS or this ADH, okay, this causes a stretch in the myocytes, right? And whenever the stretch or the preload on the myocytes increased, that will cause a release of this ANP and BNP. Whenever this ANP and BNP released, they will work through the cyclic GMP. You guys remember that? And the cyclic GMP causes the vasodilation. So the one thing you will get is the vasodilation, okay, veno as well as the vaso both. So that decreases the preload on the heart. Second thing, it will cause the natriuresis, and that's why the name anti-natriuretic peptide and the this atyl natriuretic peptide and the brain natriuretic peptide, right? Because they causes the natriuresis. They will cause a loss of sodium along with the water. decreasing the volume overload on the heart, right?
Yes.
So one thing is the loss of sodium. Second thing is the vasodilation. Third thing is the inhibition of the RAS system. Whenever the ANP and BNP is present, they will inhibit the RAS system, so thus more sodium could be lost from the body. And the final thing is the dilation of the afferent arteriole and the constriction of the efferent arteriole. Okay, so throughout the body, they causes a vasodilation, but in the efferent arteriole, they causes the vasoconstriction. So thus, you can have a more filtration fraction, more GFR, more blood flow to the kidneys. And as a result, more natriuresis. So the ultimate goal of these ANP and BNP is to cause a loss of sodium, a loss of body volume. Is that okay?
Yes.
Now, what are the activation factors for my ADH? One thing is, of course, the RAS system. Whenever I got an angiotensin 2, I will got activation of ADH. Second thing is the low volume of water in the body. That means a dehydrated state, right? And the third thing is the osmolality. Whenever you have a high osmolality, doesn't matter what your water status is, if you're having a hypervolemia or a hypovolemia, if you're having a high osmolarity, this will activate my ADH. Similarly, it doesn't matter if you're having a normal osmolarity, if you're having a hypervolemia, sorry, if you're having a hypovolemia with a normal osmolarity, this will again activate my ADH. Okay, second factor, and third is of course the angiotensin 2. So osmolarity, okay, volume status, and third is the angiotensin 2. These things will activate my ADH. Is that okay?
Yes.
So that's about my renin, angiotensin, and aldosterone system.
Hyperosmolarity increases ADH, right?
Yeah, hyperosmolarity increases the ADH. And doesn't matter in that case what your water status is. Even if you're having a hypervolemia, it will still activate your body will still activate the ADH.
Okay.
Similarly, if you're having a normal osmolarity but a low volume status, in that case, again, your ADH will get activated.
Okay.
So these are the two important factors. And third one is the angiotensin 2. Please note the location of this angiotensin converting enzyme. It is present in the lungs. Okay.
Yes.
So step one can, ask you this fact by giving you a scenario, okay, where there is a scientist who is measuring some concentration of some hormone. And what he measured is that this hormone has a low concentration in the pulmonary arteries, veins, but a high concentration in the pulmonary arteries. And they will ask you what this hormone could be. So please note, it could be the angiotensin 1 and angiotensin 2. Okay.
Okay.
So that's everything on this page. Any doubt, please ask.
So in CHF, increased ADH activation?
Yeah. In the chronic heart failure, you have a decreased blood flow to the kidney that will activate the ADH again, and that will again increases your BUN, because you know that the chronic heart failure is an important cause of your prerenal azotemia, right?
Yes.
Whenever you have a high ADH, you will always have a high blood urea nitrogen.
Yes.
Anyone? Any more doubt?
No, thank you.
Okay. Then that's about my JG apparatus. We have discussed it already. You have the mesangial cells, you have the macular denser cells, and you have the JG cells. JG cells, beta receptors, okay, afferent arterioles, baroreceptors, and the macular cells, sodium delivery. Okay. And that's why the beta blockers, the cardioselective ones especially I'm talking about, they have this beta 1 receptors on them, right? So beta blockers can inhibit your these JG cells, and as a result, they will decrease the renin. And that's why the beta blockers are a very good drugs to decrease the BP of the patient, right? Antihypertensive drugs, because they inhibit the renin release.
Yes.
Okay.
Yes.
Then some other functions of my kidney, other than the regulating the volume status. Okay. The other endocrine functions, the one is the erythropoietin. And please note the location where the erythropoietin got released. It released from the PCT, and not from the PCT just. You have some fibroblast surrounding the PCT. Okay, you call them the peritubular fibroblast. Okay, and these peritubular fibroblast cells, they will release the erythropoietin whenever you have a anemia. Okay.
Okay.
And whenever this erythropoietin releases, it will also causes the stimulation of some receptors that causes a vasoconstriction. So whenever you have a high erythropoietin, you will always get the hypertension. And second thing, whenever you have a high erythropoietin, it will also stimulate or promote the von Willebrand factor activation, and that causes the thromboembolism. So whenever you have, in a normal situation, you won't get these conditions. But whenever you give the patient erythropoietin therapy, external drug, okay, the EPO analogs, if you give them a too much of the EPO analog, then the risk is the hypertension, stroke, MI, or the thromboembolism because of activation of the von Willebrand factor. Is that okay?
Yes.
So do remember this function. Again, it's the cholecalciferol, the vitamin D. You guys know the enzyme. Where does this enzyme for the activation of vitamin D lie? 1-alpha hydroxylase. Location?
Kidney.
Kidney. Of course, it is the kidney. Where in the kidney? Where in the kidney you have 1-alpha hydroxylase? I repeated many times before, while discussing the function of all the different tubules. I told you, right? The PTH hormone and this 1-alpha hydroxylase. Where does this 1-alpha hydroxylase present? Yeah, say it again.
PCT.
Yeah, PCT cells. Don't forget that you have a PCT cells that secretes the 1-alpha hydroxylase. See, the peritubular fibroblast secreting the erythropoietin, and the PCT cells itself secretes the the 1-alpha hydroxylase that converts this vitamin D into the activated form whenever the PTH is present. Third one are the prostaglandins. Whenever you have a low volume status, okay, whenever the the blood supply to the kidney got decreased, the kidney will secrete the prostaglandins to dilate the afferent arterioles, and that will cause the increase in the renal blood flow, right?
Yes.
So in a low volume status patients, that means a dehydration or burns, or in case of any shock, you requires the prostaglandins to be there, right, in order to prevent a necrosis of my kidney. Okay, and if you give the patient NSAIDs, okay, then it will cause this condition even worse. So whenever you encounter a dehydrated patient or any burned patient or any patient with the shock, you cannot give them the NSAIDs because it will cause a damage to your kidneys. Okay.
Yes.
So do remember this contraindicated things: the diarrhea, heart failure, excessive diuresis, okay, vomiting, or no water intake for 24 or 48 hours, or something like that. Please avoid giving the patient NSAIDs because they inhibit the prostaglandins. Then the dopamine, again, it is released from the PCT cells. Okay, it will cause the dilation of your the renal blood vessels, causing an increase in the renal blood flow. Okay. Second thing, it promotes the natriuresis. Okay, just like your ANP and BNP, the dopamine also will promote the natriuresis. Okay, and it will increase the renal blood flow. Okay, no change in the GFR. Okay, little or no change in the GFR will occur. Okay, and the effect of dopamine is concentrated. It depends upon the concentration of my dopamine. If I give it in a low dose, okay, if you guys remember the general pharmacology, we have discussed that at low dose, it will stimulate D1 receptors, causing an increase in the renal blood flow. If I give them in a moderate dose, they will stimulate the beta receptors. And I give them in a very high dose, they will stimulate the alpha receptors, right?
Yes.
So at low dose, vasodilatory effects. At a high dose, vasoconstriction effects. Okay. So that's everything on this page. Any doubt, please ask.
No, thank you.
Okay. Then you have a location of different hormones that is acting on your kidney. We have discussed them already. Okay, the ANP and BNP. I told you they act on the afferent and the efferent arterioles. ANP and BNP causes the constriction of efferent arteriole and dilation of the afferent arteriole to promote the filtration, ultrafiltration. You will have more filtration of the fluid, more loss of the sodium by inhibiting the RAS system, right?
Yes.
So this is the ANP and BNP. Angiotensin 2 causing a vasoconstriction in the efferent arteriole, promoting the filtration of all this fluid. Okay, ultrafiltrate. Okay. Other functions of the angiotensin 2 is to act on the PCT part. In the PCT, it will activate the sodium hydrogen pumps so that more sodium could be reabsorbed and more hydrogen could be secreted back into the tubules.
Yes.
Right. So in the PCT, function is to activate the sodium hydrogen pumps. In the glomeruli, function is to cause the vasoconstriction in the efferent arterioles. These are the two major functions of the angiotensin 2 on the renal system, right? On the tubules. Okay. Then the parathyroid hormone, I told you in the PTH, it will activate the 1-alpha hydroxylase. In the DCT, it will activate the calcium channels to cause more calcium reabsorption.
Yes.
Then you have the aldosterone activating acting on these principal cells and the alpha intercalated cells, right? So
Yes.
causing activation of sodium channels, potassium channels, and the hydrogen ATPase channels, right? In the alpha intercalated cells.
Yes.
So reabsorption of sodium, reabsorption of bicarbonate, loss of potassium, loss of hydrogen. ADH vasopressin, two parts. Okay, either the cortex portion of the collecting duct and the medullary portion of the collecting duct. In the cortex portion, just the water reabsorption. In the medulla portion, both water as well as the urea absorption.
Yes.
Then you have the potassium shifts. Okay, you need to know all the causes which can cause a transcellular shift of the potassium inside the cell and out of the cell. Whenever you have a low osmolarity, okay, you can just remember them by some diseases. Like for example, think about the hyperglycemia, diabetes. Okay, in the hyperosmolar state, you guys know that you're having an outward shift of the potassium from the cell, right?
Yes. Hyperkalemia. Yes.
Right. So in the hyperosmolarity states, you will have an outward shifting of the potassium from the cells. And
Yes.
similarly, opposite to my hyperosmolarity, you are having a hypoosmolar state, shifting the potassium inside the cell, causing the hypokalemia.
Yes.
Right. Similarly, digitalis or digoxin, which will activate my sodium potassium ATPase pumps. Inhibiting my sodium potassium ATPase pump, so that this potassium cannot go inside the cell, and as a result, you will get a hyperkalemia by giving the patient digoxin, right?
Yes.
Whenever a cell injury occurs, okay, the cell will die. It will release all the electrolytes, all the solutes present inside the cell. One of them is, of course, the potassium. So a crush injury, rhabdomyolysis, tumor lysis syndrome, they all causes a lysis of the cell, shifting the potassium out of the cell.
Yes. Hyperkalemia. Yes.
Yes, you will get the hyperkalemia. And remember one more drug that will activate the potassium channels. Any skeletal muscle relaxant drug? SMR drug that causes the activation of my potassium channel, causing the hyperkalemia. Succinylcholine.
Yes.
So you can remember them by the fact that succinylcholine can cause a very this contraction of my muscles.
Yes.
Remember the malignant hyperthermia?
Yes. Yes.
Rapid contractions, you will get a rhabdomyolysis again.
Yes.
So you can remember this by the fact also that succinylcholine can cause the malignant hyperthermia, that can cause a rhabdomyolysis again, that can cause the hyperkalemia. So one of the side effects of my succinylcholine is to cause the hyperkalemia by shifting the potassium out of the cells. But the real reason is actually to activate the potassium channels. This is the fact just to remember, by correlating things you can remember. I told you the acidosis can activate my, these sodium and hydrogen pumps, right?
Yes.
Secreting all the hydrogen into the tubules and causing the reabsorption of the potassium. So whenever you have acidosis, that will cause a hyperkalemia. Similarly, whenever you have a alkalosis, that will cause a hypokalemia. The beta receptors, that will directly activate the sodium potassium pumps. So when the beta receptors are present, when they're stimulated, you will have a inward shift of potassium. Whenever you give the patient beta blockers, it will cause an outward shift of the potassium. Now the clinical correlation, whenever you have a myocardial infarction, I told you whenever a cell dies, you will have inhibition of the sodium potassium pumps, right? Because of loss of ATP, the irreversible injury and the reversible injury, remember?
Yeah.
In that case, because of the inhibition of the pumps, you will have a intracellular shift of the potassium. So one of the things that you will get whenever you encounter a patient of MI is the low potassium. Hypokalemia they always have.
Yes.
Similarly, whenever stress happen, any kind of infection or any reason that can cause the activation of sympathetic system, you will always have a beta stimulation, and that will cause again the intracellular shift of the potassium, right?
Yes.
Similarly, adrenergic agonists like the pharmacologic drugs, albuterol, dobutamine, alcohol withdrawal, they will all cause the beta stimulations. They will cause the hypokalemia. In the hyperthyroidism, you will have a more activation of beta receptors. And one of the things that you will get in the hyperthyroidism is the hypokalemia. Right?
Yes.
So just correlate all these things together. Okay. And now comes the insulin. Okay, just again think about a diabetes mellitus. In the diabetes, you're having a high level of potassium because you have low insulin, right?
Yes.
So insulin always causes the just like the beta receptors, insulin causes the activation of sodium potassium ATPase. So more potassium will be shifted inside the cell. Whenever you have an insulin, you will have a hypokalemia. Remember the refeeding syndrome?
Yes. Yes.
I told you will get a hypokalemia, hypomagnesemia, and hypophosphatemia because of an intracellular shift of all these electrolytes inside the cell, right?
Yes.
So insulin will cause an intracellular shift, and similarly, low level of insulin, that means in a diabetes, in the hyperosmolar state or in a diabetic ketoacidosis, you will get a outward shift of the potassium from the cell. So you will get a hyperkalemia, but the overall potassium level inside the body is depleting, right?
Yes.
Succinylcholine can also do that. So these are the reasons why you get the outward shift or the inward shift of the potassium, and then you will get a hypokalemia or the hyperkalemia respectively. Okay, now the other reasons that can cause the hypokalemia. Okay, one is the digoxin we have discussed. Non-selective beta blockers, they can cause a hyperkalemia, because of this extracellular shift. In the hematology, you heard about the heparin. Heparin can cause the hyperkalemia. Please remember that. Heparin, HH. Okay. Then the skeletal mesoreluctants like these, the succinylcholine. Okay, they can cause this hyperkalemia by activating the potassium channels. Cyclosporins also can cause the hyperkalemia. Trimethoprim can cause the hyperkalemia. And what is this trimethoprim?
Spectrum.
Yeah, antibacterial drug, right? Trimethoprim sulfamethoxazole, this combination, right? Similarly, potassium sparing diuretics can cause it. Angiotensin converting enzyme inhibitors and the OR drugs can cause the hyperkalemia. So these are all the causes of the hyperkalemia. Okay.
Yes.
Whenever you have a diarrhea, whenever you have a vomiting, you will have a loss of potassium from the body, a cause of hypokalemia. Whenever you have a tumor, in that case, tumor requires the potassium, right? Like the AML or, and whenever you give the patient GM-CSF therapy, new cell formation requires the potassium for the functioning. In that case, you will again have a hypokalemia as the side effect. Whenever you have a sweating, you will have more solute loss, including the potassium. So again, it will cause the hypokalemia.
Yes.
Right? So these are all the causes for the shifting, and these are the other causes that can cause a hypo or a hyperkalemia respectively. Any doubt on this page?
Is that all chemotherapeutic medication cause hypokalemia or?
Hyperkalemia they can cause because of a tumor lysis syndrome.
Yes. Yeah.
All of them can cause it, right? And that's why you give the patient allopurinol and all other drugs, right?
Yes.
Now you need to know all the symptoms of different electrolyte imbalances. Okay. For the sodium, remember, you will get the neurological symptoms first. Okay. So for the hyponatremia, symptoms include the coma, okay, drowsiness, anorexia, nausea, vomiting, GI symptoms. You will get a lethargy, weakness will be there, patient unable to stand up from the bed, get out of the bed. Tendon reflexes will be decreased. You will get the hypotonia of the muscles, hyporeflexia, limping or weakness will be present, orthostatic hypotension will be there, seizures, headaches, cramps. So majority of the symptoms are the neuronal symptoms, right?
Yes.
And other symptoms are the GI symptoms. So neuronal symptoms with the GI symptoms, think about the hyponatremia. Similar thing, go for the high concentration, irritability, stupor, coma. Again, these are the symptoms you will get in the this hyponatremia. Okay.
Yes.
Causes of the hyponatremia includes heart failure first. Okay. And all the causes, like the cirrhosis, it can cause it. Okay. The chronic kidney disease can cause it. Okay. SIADH can cause it, because in SIADH you're having a too much activation of ADH, right?
Yes.
That will cause a free water reabsorption. You will get a low sodium. In the chronic kidney disease, you cannot reabsorb your sodium. That will cause a loss of sodium from the body. In the cirrhosis, your liver is not functioning very well. Okay, that can either cause the low sodium levels. In the heart failure, you're having an activation of ADH and this hypervolemic state. So you will get a dilutional hyponatremia, right? Diabetes mellitus causing a overall natriuresis, and because of this high volume condition, again our dilutional hyponatremia is present. So these are all the causes of the low sodium levels. Okay.
Okay. Yes.
Symptoms: nausea, malaise, stupor, coma, seizures. These are all the very much, so neuronal symptoms are very much common for the sodium. And then the GI symptoms, 2 symptoms only. For the potassium, okay, with the hypokalemia, you will get a flattening of the T waves. Okay. Because of this low potassium levels, you can also have a QT prolongation. Remember, low calcium level, low potassium level can cause a QT prolongation.
Yes.
Right?
Yep.
So this is a low, so the QT prolongation will be there. Okay. Flattening of the T waves will be there. Arrhythmias can occur, of course, because the potassium is required for the action potential. Muscle cramps, spasms, weakness. So symptoms are very much common to just like of calcium, right? Because in calcium also you're having a spasms, you're having a weakness, you're having a cramps in the muscle. So how would you differentiate between the hypokalemia and the hypocalcemia? That is the presence of these seizures first. You won't get the seizures in the hypokalemia. Okay. You will get this tetanus type of thing. Tetany will be present in the hypocalcemia. It is not very much common with the hypokalemia. 2 other important signs that you will see. Yeah. One is the Trousseau sign and second is a Chvostek sign. Remember the Trousseau,
Yes.
right? Remember the
Yes.
Trousseau sign? What does it?
The spasm of the
Spasm of the thenar eminences, hand muscles, right? Whenever you tie, this pressure cuff on the arm, right?
Yeah.
Second thing is the Chvostek sign, and whenever you tap on your facial nerve, on your face, you will have a focal contraction of the facial nerve region, right?
Right.
Chvostek sign. So these 2 signs are also present in the hypokalemia. Sorry, hypocalcemia.
So
Okay.
Trousseau sign, blood pressure cuff is that one, right?
Yeah. BP cuff you will tie on the arm, and you will get a focal contraction in the muscle of hands.
Yes.
Okay, so and please note that calcium is an inhibitor of sodium channels, and because of a low calcium levels, you're having the activation of sodium, and that's why you're having a too much contraction. That's why all these spasms, tetany, and the seizures and all these things. Okay.
Yes. Yes.
Similarly, with the hypercalcemia, I told you, you will have a sclerosis of the collecting duct, right? Malignant hypercalcemia, remember?
What is that again?
I told you, this malignant calcification, I told you that you will have a sclerosis of the collecting duct.
Okay. Yes.
Dystrophic calcification and malignant calcifications,
Yes.
remember?
Yes.
Right. So because of this sclerosis of the collecting duct, you will have a loss of ADH receptors, and that causes the loss of all the water, free water from the kidney, right?
Yes.
So symptoms will be polyuria, polydipsia, that means a diabetes insipidus you will get with the hyperkalemia. You will get a recurrent stones, okay? Bone pain you will see. Psychiatric symptoms can also occur. Constipation is a very important, because whenever you have a hypercalcemia, it will inhibit the sodium channels in the neurons or in the smooth muscles, right? So the contraction of the smooth muscles never happen in your GIT, and as a result you will get the constipation because of a decrease in the smooth muscle contraction. So constipation, muscle pain, polyuria, polydipsia, multiple recurrent stones, bone pain, these are the majority symptoms of the hypercalcemia. Okay.
Yes.
Hyperkalemia, you will get a peaked, see, in case of hypo, you're having a flattening of the wave. In case of your hyperkalemia, you're having a peak T waves. Arrhythmias, muscle weakness, widened QRS are the other things. With the magnesium, you can get a torsade de pontis episodes. Remember, QT prolongation with the hypomagnesemia, hypokalemia, and hypocalcemia.
Yes.
So
Yes.
you will get a low magnesium level that can cause the QT prolongation. Second thing is the hypokalemia, of course. You will get it. Hypocalcemia, because I told you, whenever you have a low level of magnesium, it will initially stimulate the PTH, and if too much level of this potassium decreases, it will inhibit the PTH, right?
Yes.
So hypocalcemia is another side effect. Tetany can also happen. Similarly, with hypermagnesemia, you will have a loss of deep tendon reflexes because of this high level of calcium you will get. Sorry, a low level of calcium is again present, not the high level of. Okay, so deep tendon reflexes because it will inhibit some kind of receptors. I forgot to tell you one thing in the neurology, and these are the NDMA receptors. I will cover them in the next session. Okay, in the next class, I will tell you about all these receptors of the NDMA. Okay.
Okay.
And the role of magnesium in them. So just wait for the deep tendon reflexes there. You will get a lethargy, bradycardia, hypotension, cardiac arrest whenever you have a hypermagnesemia. Okay, not much important. I've never encountered any question on the hypomagnesemia or the hypermagnesemia. Just know that this low level can activate the PTH, and a very low level can inhibit the PTH. Phosphate you required for the bone formation. If you're having a low phosphate, it will lose the bone mass. You will have a bone loss, you will have a bone pain, osteomalacia, rickets can happen. With the high phosphate level, the calcium phosphate stones can form. You will have a metastatic calcifications, because you guys know, whenever you have a chronic kidney failure, I told you one thing, that all this phosphate will combine with the calcium, right? And start depositing on the tissues.
Yes.
So this metastatic calcifications can happen, and you will get a hypercalcemia because all of this phosphate will combine with the free calcium,
Yes.
causing the hypocalcemia. So these are all the side effects of, all the symptoms of different electrolyte imbalances. The majority important one are the sodium, potassium, and calcium, because symptoms are almost similar in all of them three. So you need to be differentiate between these three before choosing the option. Okay.
Yes. Yes.
Then different renal disorders. One is the SIADH that we have discussed in the endocrine. High level of ADH will cause a high blood pressure because of free water reabsorption. Renin will be decreased because you're already having a very high volume status. Aldosterone will be decreased. Magnesium, calcium remains same. Whenever you have a hyperaldosteronism, the RAS will be inhibited because it is the high level of aldosterone only. It could be primary, it could be secondary, of course. If you are having a primary hyperaldosteronism, that means the primary defect is the high level of aldosterone. That will give a negative feedback to the renin, and it will promote the absorption of sodium water. So more blood pressure will get. In a renin secreting tumor, again, you're having a high level of renin that will cause a high level of aldosterone and that will cause a high blood pressure. The difference is you won't get any edema in the primary hyperaldosteronism because of a aldosterone escape mechanism, right?
Yes.
And what is this aldosterone escape mechanism?
Don't know.
See, in the aldosterone escape mechanism, first thing, because of this high volume, you will have a stretch of myocardiocytes. And whenever the stretch of myocardiocytes increase, what thing they will release?
ANP, BNP.
ANP and BNP. What is the function of my ANP and BNP?
Director.
Dilation first and
Natriuresis.
yeah, exactly. Natriuresis. You will have a loss of sodium, loss of water. Second thing, you will having a inhibition of the RAS. So all the effect of this angiotensins and all these things will be inhibited.
Yes.
So these two things will promote the full action of aldosterone, and as a result, you will have high blood pressure with a normal body volume. Similar thing goes for the SIADH. You're having a normal body volume because of this ANP, BNP, and inhibition of RAS. But again, a high BP is present and a hyponatremia is present, right? In SIADH.
Yes.
In the
Yes.
Bartter syndrome, and does anyone remember where's the pathology lie in the Bartter syndrome?
Ascending.
NaCl potassium transporter.
What channels?
It works like a loop diuretic.
Yeah, loop diuretics, remember? Yeah, exactly. You will have an inhibition of sodium, potassium, chloride channels. Okay. So aldosterone levels, it will increase because of loss of all this fluid from the body, like this diuresis will happen. Plasma renin again will rise. Hypokalemia you will get. This metabolic alkalosis you will get. Gentleman syndrome, working like the thiazide diuretics, again, you will have a same high aldosterone levels, high renin levels. But in this case, you're having a low urine calcium, high serum calcium because of this calcium reabsorption, and a low magnesium levels. In case of Bartter syndrome, working just like my loop, you will be having a high urine calcium, right? Liddle syndrome, or the syndrome of upper mineralocorticoid axis, working like a hyperaldosteronism, but a low level of aldosterone, a low level of renin, and high level of, and this high BP, right?
Ali boy, yun sa kuwan.
Step 1 can also ask you.
Helado.
Step 1 can also ask you about the acute causes of hypocalcemia. So please remember all this. One is the neck surgery. I told you about this. Surgery of the thyroid gland, right? Whenever you have a thyroid, you can also have a removal of parathyroid, right?
Yes.
If the parathyroid glands are lost, you will have a acute hypocalcemia. Okay. Just after surgery, you see that in a next day, at the present day, the patient is absolutely normal, but after one day, the patient suddenly develops the hypocalcemia. Pancreatitis, because all of this fat will get saponified with the calcium, right? The saponification reaction. You will get an acute hypocalcemia after the pancreatitis. Tumor lysis syndrome, all of the phosphate combines with the calcium, you will get an acute hypocalcemia. One day you give the drug and next day patient develops a hypocalcemia. Chelation therapy, in the blood, I told you about the citrate that will chelate this calcium. If you give the blood in a normal amount, like 1 or 2 units, nothing will happen. Only a slight decrease in the calcium levels. But if too much of the blood is transfused, like 2 units or like 4 or 5 units in a severe blood loss, right? The citrate will chelate all the calcium. You will develop a hypocalcemia immediately after the blood transfusion. Okay. Yes.
Yes. Why hypercalcemia, pancreatitis?
Because in pancreatitis, you're having, this lipase activation. Remember, lipase will degrade all these triglycerides into the free fatty acids. And the free fatty acids will combine with the calcium via saponification, right?
Yes.
Forming all these salts that deposit on different tissues, and you will get this hypocalcemia.
Yes. Okay.
Hypercalcemia is a cause of pancreatitis. And after pancreatitis, you can get a hypocalcemia. Remember this like that, okay?
Okay. Okay. Thank you.
Any note on this page?
No. No, thank you.
Okay, so let's wind up the session for now here. Okay.
Thank you. Yes, thank you.
Okay. Thank you so much, everyone. Okay. Thank you so much, both of you, for joining me. It's just two of you.
Thank you.
Thank you.
Thank
I
you.
don't know what happened to everybody else.
Yeah, it's just two participants today. So much for the audience. Okay. Thank you so much, anyways.
Thank
At
you.
least I got to